All right, so welcome. Wow, not sure really quite where to start because there's a lot regarding sickle cell disease. So let me start by just saying thank you for being here. Really appreciate it. And even the collaborative. So what I want to do first is talk about what the collaborative is, and then have you all um, just give some information about your organization. Those organizations that are not here, then we'll talk and give a summary of those that aren't here. So, goodness, California, sickle cell disease. Been around for a while. So, Kaya Wellness Center has been around for 25 years. And so there is another organization, Sickle Cell Disease Foundation, and they're known more for the camp experience. So, maybe familiar with camp. Um, what we found is that there are others who are grassroots, and the goal was to bring together those other organizations that are grassroots to come together so that we know what we're all doing and that we're not stumbling over each other. We're able to support each other, and also for Kaya Wellness Center to help build capacity for those other organizations. So the California CBO SCD Collaborative started, goodness, 5 years ago. And so we've been coming together here in San Luis Obispo. We found that it was central. It's also beautiful. And so we have organizations that are both in northern portion and the southern portion. So we came together. In the past, we would come together just for the one, we would get here on a Friday, have this beautiful dinner together, and then we meet on Saturday for the entire day. And when I do agendas, it's pretty packed. And then we would depart. But we wanted to, what we are decided to add was wherever we're going to have our meetings, we need to now have a provider component. So there's a reason now that when we're here, we'll let the community know that we're here and to educate them on sickle cell disease, best practices, pain management, pathophysiology, all of that. So that's why we're here. So I want to move forward and just name all of the organizations first. And then when you're here, if you're here, I know that you're here, come on up so that the camera can see you, and then talk about your organization. So the organizations that are under the California SCD CBO Collaborative are SCCAC, which is Wanda Williams and Julie. They're located in Northern Cal, Oakland. There's SCAA-SF, which is San Francisco, and they're represented right now with Kimball Torres. There's also Sickle Cell 101, and that is managed by Cassandra Trimno, and she's now where I was supposed to be as well, in Oman. So she's speaking now in Oman right now, so she can't join us. So we'll talk a little bit more about what they do. Also is the World Sickle Cell Federation with Nita Thompson and Rochelle. There's Kaya Wellness Center represented as well. The Hina Patel Foundation. So both Bhavna and Dr. Patel, they could not be here. And then two other organizations, KISS Foundation, as well as Sickle Cell Disease Foundation of Orange County. So those are the ones so far that are under our umbrella. So for those that are here, Kimball, I'm going to have you come up and representing Sickle Cell Anemia Association San Francisco. And then just give an intro and then just some background about the organization.
Intro to myself, or
Who you are,
okay,
and then the organization.
awesome. Thank you. Thank you for having me here today. My name is Kimball Torres. I was born and raised in San Francisco, and I am the outreach director for Sickle Cell Anemia Awareness San Francisco. As I mentioned, I was born in San Francisco, born and raised there. Got recruited to play college football over at the University of Minnesota, where I graduated my degree in pre-med biology. Then I came back to the Bay Area and worked in biotech for 5 years. After that, I decided to start my own business in athlete development and life coaching. And along those lines, helped Nadina and Antoine establish Sickle Cell Anemia Awareness San Francisco. And in that, so we've been in operations for 10 years now. The original thought process behind it was just to have a walk to commemorate the death of Nadina's son, Kareem. Sadly, he passed away 10 years ago. And because of what was happening in the healthcare system, Nadina wanted to bring about awareness for the disease and a little bit more of advocacy for it, because poor Kareem didn't get the help and the attention that he needed, nor the care and love that he deserved to have. And with that, through the walk, we kind of started to see a need for it. A lot of different people were starting to come to Nadina asking if she could help them out in the hospital, if there's any type of legislation, et cetera, et cetera. So at that point in time, she brought me and Antoine and myself together, and that's where we came up with the mission for advocacy and education, and that's what we stand for. As the outreach director, I do a lot of boots on the ground type stuff. I go to schools, give talks during Black History Month, which is February, to all of the schools in San Francisco, talking about sickle cell, the history behind it, the way people are treated in the healthcare system. Our main goal at this point in time is definitely to educate everybody on it and to have testing for everybody available for it. So that's us in a nutshell. So thank you for having me.
Thank you. All right. Well, you're in front. So these are the, so normally we meet in October. And so there were some changes that happened. SCDAA changed their date, which was a domino effect on everything. So we're here in November, and all the other organizations had other obligations. So I am going to speak on behalf of SCAAC. And so they came out of, this is Wanda and Julie. This was actually affiliated with UCSF. And both Wanda, who's an educator, Julie is a caregiver to her son, adult son with sickle cell disease. And so it was actually part of UCSF. And I believe it still is part of. They actually have their own camp as well, which is wonderful. And I believe that's like in either July or August.
Yeah.
In those months. And so they do that. They have a Christmas party in December. And so they're there for that particular community in terms of what they do. So we really appreciate SCCAC. They've always supported our summit, which we'll talk about momentarily. And so that's SCAAC. The next one is Access Advocacy. I was hoping that Pat was still here, but Access Advocacy, which is run by and started by Adrienne Shapiro. And so it was started with Adrienne Shapiro, who is a mom of a daughter with sickle cell disease. And so her daughter would make five generations of sickle cell in their family. It was also started by Nancy Renee. Nancy Renee's grandson has sickle cell disease. So the two of them got together to put together Access Advocacy. Largely at that time, because there needed to be more legislative efforts that needed to take place. Back when they started, the only organization that was doing legislative work was SCDAA. Before COVID, they would actually have an advocacy day, which meant they wanted us to come a day early, do the training. Then we would go out and hit all the different, knock on the doors of all the different legislators. Then COVID hit, and they had to figure out how to pivot. And so they have a beautiful Sick Cells came into being. Beautiful beautiful platform of how they do it. I actually love technology. It's excellent. Some of you all have been part of that. So they have a day of training, and then they actually take the lead. And as long as they know where you're coming from, they take the time to reach out to all the different legislators on your behalf. They go ahead and schedule those appointments. All you have to do is just show up and share your story. It's phenomenal. So Access Advocacy came about through wanting to do more in terms of legislative advocacy. And then it kind of morphed into now advocacy because it's so needed at point of care. So Adrian shares how I'll never forget, unfortunately, Natasha, who passed away. I could not, she had already been turned down by 3 hospitals. She would go in, she got 1 shot, and they turned her away. She'd go to another hospital, well known, 1 shot, turned away. Happened 3 times until she then reached out. When she reached out, I said, okay, you're gonna stay there. I talked to the hospital and I said, please keep her there. It was a Friday. But I couldn't go because unfortunately my dad had just died. So Adrian went there to make sure she stayed, that they kept her. Then I checked in. It was Sunday, and I said, please do not discharge her. Can you please wait till Monday? I will be there on Monday. Well, they waited till Monday at 2:00 in the morning to discharge her. And her vitals, her was oxygen was at 72.
What? And they still.
And so 2:00 in the morning. So they waited till Monday. And so I don't know, she had called me while she was driving home from the Valley to LA. I can hear her hitting the side middle divider. She made it. Now, granted, she had a medical home, which was LACURC, but she didn't go at that time because she wasn't close by. And so by Wednesday, I said, you got to get there. And so when she finally made it on Wednesday, finally, to her best medical home, the best place that she could have been, unfortunately, she died on Friday. So as a result, with Adrian having stepped in, she saw there's more than a need because people are dying. And so now Adrian has a program of training folks who want to learn how to do advocacy at point of care. So there's Adrian and Lisa Bailey, who are now part of Access Advocacy. Let's see. We also have, who's not here, Hina Patel Foundation. So Bhavna Patel and Dr. Ami Patel, they're in Bakersfield. And that organization started because unfortunately they had a daughter diagnosed with sickle cell disease. And I believe it was at age 18 that she had a bone marrow transplant. And unfortunately, within the year, she passed away. And so that began the Hina Patel Foundation. I think in honor of her sister, Dr. Patel, went on to get her degree, and she's now at UCLA. So both the mom and daughter run the Hina Patel Foundation, and so they couldn't be here either. Usually everybody's here. Next is Sickle Cell 101, Cassandra Chimno. So hers is all online. And she has, I think, a following of minimum over 40, but I think it's over 80,000 folks international who follow her. And hers is all education about hydration, sickle cell disease, sickle cell trait, now, the gene therapy. So she found this is her niche with her marketing degree, and she puts together easy, bold, bright, easy to follow information. And her following are those people with sickle cell disease, young folks, namely, around the world. And so that's the one who's currently in Oman right now. There is Sickle Cell Disease Foundation of Orange County by Star Simmons. She's a parent of 2 children with sickle cell disease. And so that's how her organization started. I believe that her children are 10 years apart, if I'm not mistaken, give or take. And so she started that in Orange County to be able to help those persons out their way. Her specialty, though, is 504 and IEPs. She is, how do you call it? I guess you call it a mama bear. She's very aggressive at making sure that anyone who has sickle cell disease knows their rights when it comes to school, period. And so she doesn't not only just take no for an answer, she demands what they actually need. And she's been very, very successful. So she's also on staff at Kind Wellness Institute, helping our clients as well and families. Then there's KISS Foundation, Kiki Shepherd. And so Kiki Shepherd, you might know Kiki Shepherd. So if you remember the Apollo, back in New York, Showtime at the Apollo. So that was Kiki Shepherd who had the little walk. And so she has sickle cell trait. And so she started the KISS Foundation for awareness. Started off with doing more for scholarships for those who are wanting to go to school. But now she puts together these beautiful backpacks full of items and passes those out to adult persons with sickle cell disease out in LA. She has a golf tournament, actually celebrity golf tournament and a celebrity bowling. So the stars do come out to support her. And recently, I understand, she was on Grey's Anatomy. And I haven't seen it. I think somebody here has seen it. Sheila, you want to share what, you'll have to speak up so that it can pick you up.
Okay. Kiki was on Grey's Anatomy, and she was invited by Debbie, the dancer. You know Debbie
Allen?
Yes, and the producer. She showed up in the hospital room of a patient who had been hospitalized with AVN. He was a father, so they featured a full lifespan of sickle cell disease. And Kiki came into the patient's room as an advocate, and she did a wonderful job.
We need to see that.
Okay, it's available, and I've written Kiki to thank her on behalf of us, right? And Kiki and I shared, we were in the trenches, right? Kiki literally said, Sheila, I am going to let Debbie Allen know the note that you wrote so that they will know how much it is appreciated. So it wouldn't surprise me, Dr. Raleigh, Pat, and the team here, that they'll reach out again, because Kiki made that. So wow. She did a wonderful job. She stood up strong as an advocate, and she's known both by her face and her name. So that's another level of elevation for sickle cell awareness and advocacy. Yes. And to let you all know, to give due credit, one of our dear warriors, Renisha Curry, is the one who called me. We text and call each other all the time. Sheila, oh my gosh, sickle cell warrior was online and on TV. And what I loved is how the hospital went through the various complications that this father had, not just in his physicality, but also in the fact that he was a parent, like Renee and I, caring, and yourself, Dr. Raleigh, caring for someone him with sickle cell and all the complications, having to care for a child and the dynamics and the stress that he was going through to leave that child without care. So it was a well-written script that I think we should have a copy of. Maybe I can ask Kiki to
Thank
see
you.
if we can get that.
I
Okay.
agree. I'll talk to Kiki as well,
Well,
to let her know.
Was it an episode for this season or?
it's this season. It's if you have Spectrum or anything, you could literally go on your TV. Right, you know how they retain them and you can go back for the entire season 17 or whatever Grace is. It's
Yeah.
episode number 3.
Number 3. No, nice.
I think they're on episode, I think they're season 37.
Okay, then you go 99, okay.
Well, that's Kiki, who is not able to be here. That's KISS Foundation. And so finally, we're going to talk about Cayenne Wellness Center. I'm going to have first Pat and Sheila come on up, and then I'm going to introduce the rest of our team. But Sheila, can you come on up? So Cayenne Wellness Center, I am Dr. Carolyn Rowley, Executive Director. 25 years started Cayenne Wellness Center. And so, again, the mission pretty much is to make sure that everybody has evidence-based care, period, and that their quality of life is improved. We currently serve the entire state through our compassionate community health workers, community health worker assistants. We purposely use compassionate in front of their title because that is actually a necessity in order to be hired, because the work is not easy. And so it can be long days, long weeks, weekends as well. We provide transportation, childcare, mental health, respite care, housing. We have a housing navigator, and the list goes on. We have a few initiatives such as STAC, which stands for Sickle Cell Trade Awareness Campaign, March on Hospitals, which we do plan on going and with civil disobedience, being in front of hospitals that are not sickle cell friendly to, again, make a statement. So those are just some of the things that we provide. However, I'm going to have Nurse Pat speak on behalf of Cayenne Wellness Center as well, and her role and what we do, and as well as Sheila, who pretty much has been an ambassador for the entire Inland Empire.
So I'm going to apologize to you guys first. You're going to continue to hear my phone ring. And the reason for that is I have a patient whose family called me, who was admitted to the hospital, and she is in the ICU.
Oh. They
They just intubated her, and so I need to be close to them.
Yeah.
So my phone is going to ring, and then there's another person that just called me she has sickle cell disease, and her mom has sickle cell disease, and she's having a lot of issues as well. So I'm going to be in and out on the phone. Cayenne Wellness. So Cayenne Wellness has a special place in my heart, primarily because of Carolyn. I met Carolyn as a young person, when I was a younger person. And we connected, and she went off to school, and she came back and took me off to school with her for a fight that she was involved in with all the crazy people where she was, So we went back there like we had some authority. But I do think that we made a difference just by showing up. And so when she came back to California, we had a support group, and she participated in our support group. And the only reason for having that support group, or even for having the conference that we had started at that point, was there was a young lady who I was caring for who said, we have sickle cell disease and nobody knows about it. And we need to make sure that there's more education out there for people with sickle cell disease. And so she said, we should have a conference. And so I said, okay. And so at the time I was working at the Center of Excellence at LA County USC. as their nurse who was in the process of organizing that program. And we decided that we would have alongside NAACP, because the person that approached me was a member of NAACP and her family was very active in that role. And so we started the conference. And so over the years, it was a little conference then. It was a one-day thing. We came in, we educated, and we informed. And then we were there available to people if they needed help with people with sickle cell disease. It's got to be so much bigger than that now. It's days long. It's a year of preparation for it. And so, it's made life for people with sickle cell disease better because there's more information out there. Number one. And when she talked about community health, the community health workers, all I could think about is 3 C's: concerned, compassionate, and connected. Okay? And so when I think about community health workers, I think about that, how much they pour into the population that they serve. And you can use my 3 C's.
I will.
I'm allowing you.
So I just hand off what God gives me, okay? And so I just want for everybody to know and understand how much people with sickle cell disease go through and how much they tolerate. Because I'm not sure if I had sickle cell disease, I'd be able to do the things that this population does and does so well. They even suffer well. They show up, they are sometimes mistreated. They are sometimes disregarded. They are sometimes labeled, but they are always there, and they are always hoping that the next experience they have will be a different experience and a better experience, and looking for the possibilities, related to what can get better? What can I do as a person with sickle cell disease to help? Because they understand that those of us who provide care to them often do not understand sickle cell disease. We may understand what the textbook says, but we don't understand the life experience. And so I got into this arena because, I tell everybody I got tricked into it, okay? It was not my desire to work with people with sickle cell disease. And I actually decided one summer after becoming a nurse that I needed to do something in my community.
Mhm.
And I said, what population is disproportionately affected? What disease, And when I didn't Google it because we didn't have Google then. When I researched it, through the encyclopedias and that kind of stuff, I found sickle cell disease. And so I found that they had a camp for sickle cell disease. And I said, maybe I'll volunteer as a nurse at that camp this summer. It was going to be a one-time thing, you guys. Do my duty and move on. And when I got there, my experience was so enriching. Watching these kids in pain and going through the things they went through made me feel, and then there were some adults there with sickle cell disease, so I got an opportunity to talk to them. And there was a doctor there, Dr. Cage Johnson, who was a hematologist who served so many people and served them so well, And when he didn't serve them well, I was always there, what's up, So at camp, he saw me interacting with children with sickle cell disease and adults with sickle cell disease and wanting to help them. And I didn't know what I was doing, and he said that he was in the process of starting a center of excellence. He was applying for funding. He was waiting for the NIH to approve it, and he would open a center of excellence. And he said, if I try to open that center of excellence, will you come and help me? And I said, yeah, sure. He was an African-American doc, young like me, and I was like, NIH ain't giving him no grant for no lot of money to take care of people with sickle cell. So in my scope of understanding, he was never getting that sickle cell center of excellence. So I agreed to come on and help him. And I didn't hear from him for a whole year. A year later, my phone rings and I answer the phone. The other end of the line is Dr. Cage Johnson. And he said, I got the money. When can you start? And I was like, I was just playing. I got a good job. I'm not looking for no other job. And I had to really work with myself to leave where I was, because I was working with a nurse we were both from Mississippi. And she had decided, and she looked like me, and she had decided that I was going to be the person that replaced her, and she was moving toward retirement. So she was going to make sure that I had everything I needed to be successful. She wanted me to shine like she was shining. And so I had agreed to be her successor. And so then I was stuck between these two spaces, and I had to figure out what I was going to do. And for some reason or the other, I guess God's will was for me to be in the sickle cell community. And I'm going to tell you what I tell patients all the time. I am who I am because of who they are, you know, and what they experienced and what they've gone through, you know. I would not have known how to take care of people with sickle cell. I didn't even know what sickle cell disease really was, you know, and I certainly didn't know all the complications and all the manifestations of sickle cell disease. But once arriving in that spot, I was determined that I was going to do the best I could do for people with sickle cell disease, because I saw how they suffered and all the things they went through, and I saw deaths very early, you know. And so that's why I am where I am. You know, I'm retired. My kids say I love sickle cell more than I love them. Okay, I assure them I love them differently. But the thing I want to say is that people with sickle cell disease do not get fair treatment. They don't get what they deserve. They don't get what they need in many cases. They're denied things that people know will help them. And I don't know what that's all about, you know. And then they're reminded that, you know, most sickle cell patients don't live to be this old. But they don't live to be this old because they give up on life in instances. When you get tired of suffering, when you get tired of being denied your rights as a person, when you get tired of struggling hard, you determine that life is not worth the living. And so even with all the complications of sickle cell disease, a broken heart is far more damaging than that. And so I'm in sickle cell disease, in the sickle cell disease community, because I love sickle cell. I love the folks that are affected by sickle cell. I love what they've poured into me. They've made me a better person. I love that they give me a desire to wake up every day and fight for them, and fight for their rights, and fight for their ability to live the same kind of life those of us that live good lives should be able to live, you know. And so that's my story, you know, and I'm sticking to it.
Okay.
You know? And so when I'm no longer here, my legacy is that I love sickle cell individuals. And I believe in my heart of hearts that they deserve everything good and nothing bad, you know, and that they deserve to be regarded, respected, and lifted, and treated in the way that they should be treated in order to have the best possible life with a horrific condition that wreaks havoc on every organ in your body. And yet people are willing to give folks with other things the treatment they need, and unwilling to take care of people with sickle cell disease in the way they need to be taken care of. So that's just how I feel. And so I work with Carolyn and I work with all the other organizations because they're working toward better life for people with sickle cell disease. And so you guys are here because you care. For those people who aren't here because they care, hopefully one day they'll wake up and they'll realize the importance of people with sickle cell disease and how we all deserve to be treated in a humane way and provided the services that we deserve.
Thank you.
So you're not really retired.
But
You're not really retired.
I am retired.
No, you tell the truth.
I tell you what I'm retired from. I'm retired from people limiting my voice.
There you go.
Yeah.
That's what I'm retired from. You move outside of an institution so you can speak your truth and your reality.
Excellent. Thank you, Pat. Thank you, Dr. Raleigh. My name is Sheila Marchbanks, and I feel so very blessed to be here, to be in your space. I feel even very blessed to be what I am labeled, which is a sickle cell ambassador. Not only am I a sickle cell ambassador, but I am also a mother, a wife, a grandmother, a warrior. I live with sickle cell disease. And for the first 45 years of my life, knowing that I had sickle cell, but being a professional woman in aerospace, I literally lived with sickle cell on the down low. I did not let anyone know, per se, that I lived with sickle cell disease because I didn't want to be limited. It seemed that intuitively I understood there was a stigma and a limitation. And I was raised with basically, the scripture wasn't said to me, but this is basically what I was raised with. My job description. You can do all things through Christ who strengthens you. So I never grew up with limitations. I grew up in a family that pushed me forward to get my education and to serve and to work. And I'm the first of 4 children, so I'm like little mom in my family too. So as I came into the sickle cell world, I first was introduced formally to the sickle cell world through Pat Corley. Being pregnant with my son, having major complications. To this day, I don't know what angel gave me a referral to Pat's number, but I was told there's a nurse at USC that can help you. Literally, that started a life that I wouldn't exchange for anything. You know, we look at sickle cell and we say, oh, the pain, the complications, the difficulties. But let me tell you something, I look at the gift. I wouldn't know any of you if I was not introduced to this world. I wouldn't know the people whom I've served for 13 years. You know, after kicking and screaming and not really being involved with serving because I was working in aerospace, I'm a wife, I'm a mom, I'm a Sunday school teacher. I had a lot on my plate. I didn't have time, but Pat and Carolyn never gave up on me. So when the Inland Empire, when it was identified at one of our conferences at Knoxbury Farm, the second highest population of sickle cell patients happened to be in San Bernardino County, Riverside County combined, the Inland Empire. There was little to nothing for sickle cell warriors, for their families, because it's not just the warriors, but it's the families and the support groups and the providers. So once that was identified, we had an inroad into the Inland Empire. And so as a team, we started serving the Inland Empire. I would say well over 50 to 100. I know it's more, it's 50 actively, but you know how people are in and out. Over 100 individuals we've served. And that's been 14 years in November. November of 2011. Is that mine? Okay, I thought I turned it off. So, as a result of serving and building relationships, for me, everything, the value in life is relationships, regardless of what title you wear or where you come from. Building relationships with people. And to be honored to have 13 years of building relationships in the sickle cell community, let me tell you what it's done for my life. I have grown as a human being. I have expanded the quality of my life. Because when you meet people who have different challenges, you meet people, you may have an issue yourself and not know that you think you're alone. And then they'll give you a hint on a solution. I've received so much from the warrior community, from the sickle cell community, those who live with the trait, the disease, the providers, the family members, the cousins, the in-laws, and the outlaws. I've grown so very much as a human being. I always say that living with sickle cell disease and now serving as an ambassador at large and working directly as Kyan Wellness, working with Dr. Raleigh and Pat, and Mary and Adrian and Donna and all the CHWs, how my life has grown, the quality of my life. Because when you're around people like yourselves and in spaces like this, we learn, we're challenged, we're expanded. So my quality of life is off the roof. Then I look at my quantity of life. As a sickle cell warrior, many of us will live in denial. We could have complications. We could have issues that we don't want to really kind of acknowledge, perhaps not have addressed, perhaps not advocate for our own very selves or teach our family members to advocate for us. So I can tell you that I've had some sickle cell complications, one being acute chest syndrome, in which I was in denial, but I reached out. And Pat said, don't you dare stay home another day. Do you know, Sheila, you're playing with your life? No, I didn't know. So through following her advice, I got medical care. And as a result of having that compassionate connection, as you said, I'm gonna borrow two of your C's, when other warriors are dealing with complications and things that threaten the quality and the quantity of their lives, I'm there to encourage them. Why? Because I experienced the benefit of that. Dr. Raleigh has been in my corner, up one side, down another. I've been given the opportunity to lead and teach, advocate, and educate through the organization that they originated in the Inland Empire. I have been continued to have the opportunity to represent Kind and Wellness at health fairs. Because, you know, I'm a social butterfly. Anybody that knows me know, I love having fun. So if there's a health fair, I want to show up, pass out our materials, talk to people, get their contact information. That is a great joy of mine. To share expands my joy in my life. So as a result of having this opportunity to work with Kind and Wellness, I'm part of the planning committee when we put together the summit. I'm invited in on educational seminars like the SCDAA and things like that. Enrichment and education that has just literally made my life so rich. I have a master's in MBA, master's in business administration, to have a platform in which I'm able to utilize my educational training, my lifelong experience, my humor, my fun side, organizing activities. I am the type that I don't just limit myself to perhaps the sickle cell community in that sense, that I pull together communities that we have fun. We go out and we have plays, and we not have plays, but we attend plays. Just building a network, and that no matter where I go, I'm going to share a little bit about sickle cell. I'm going to tell people to get tested, because at a certain age, you know, with newborn screening coming in the 80s and 90s, right? I believe I got my years right. There's a large population of people that carry the traits of hemoglobinopathies that are not just sickle, but they're the other alphabet. So I believe that I'm called to help educate and to expand people's exploration of the consideration that you may not have the S trait, but you or your partner may have C, beta thal, D, O Arab, or any of the other variants. Those genes match with the sickle gene, make babies like me with sickle cell disease. And I'm telling you, I speak with parents who cry, where there's denial, where their babies 2, 3, 4, 5, 1 up have sickle, not sickle cell anemia, not SS. They may have SC, or like myself, S beta thal, symptomatic. And because they were not cognizant, the partners were not cognizant to get tested before the baby was born. These parents are dealing with the anguish of that. So part of my mission that I believe the Lord has given me is to be an ambassador and to educate and to make people aware of those other traits that exist. Because too many families are faced with babies, their loved ones, infants, being born, and then finding out after the baby is born that they carry a trait. It happened in my own family, my very own family. So I just want to say I thank you, Dr. Raleigh, Pat, and the rest of the team for this opportunity. And I want to thank my husband for being a wonderful support. He is always there, 100%. And I'm very, very blessed. He's known me since I was 12. And the first question I asked him was, because I was taught to punish squares when I was 10 years old. So I said, do you have sickle cell? So I had to screen him. And no, he doesn't. Thank you very much.
So, Renee, then Donna, and Mary. So Renee, can you come up? Just introduce yourself. But you can come up, please.
Oh.
And so we are going to have an opportunity for the warriors to share their story. But if you can just say who you are, and then Donna and Mary, and we will then move into our pathophysiology with Dr. Ami Patel.
Renee Kirby. I have sickle cell disease, and I'm an advocate, an author, a mother, wife, Six Cells ambassador, and I enjoy what I do. I'm actively in crisis right now, but you would never know it because that's how we show up.
Shows up.
I'm having a crisis in my hip and my left thigh. I have avascular necrosis that I'm dealing with at this point. And I think that's it for now.
Thank you for being here.
You're welcome.
Thank you. And then we'll have Donna and Mary.
Hello. I'm Donna Giaconisi. I'm the Executive Program Assistant for Kind Wellness. So I help Dr. Raleigh with a lot of things, research, getting pricing, all kinds of things, help Mary with the programs, help make it all come together.
Thanks, Donna.
And she wears those beautiful scarves.
Hi. Hello, everyone. So I'm Mary Alcocer. I am the program manager at KM Wellness Center. I've been with KM for almost December 13 for years. I know the date because I remember my interview with Dr. Raleigh, and her question was like, how soon can you start? So I remember that that Monday, which is December 13, when I started with her. And the organization. I work in the programs, I work with the planning, I would work with the CDOs. I don't work so much with the clients, however, such in this case with Renee, and whenever we have speakers, moderators, we always intend to have our workers to be part to some extent. So I get to know them, and yeah, I do agree with Sheila, this kind of like growing networking that I've created. Like my background, I have a master's degree in international security and human rights. So, and I recently, funny to say, but I recently was asked to present in new technologies and the development of new technologies in conflict. So in war zones and such, and what are the consequences of it. And so I'm always kind of updating and such, and I think it's really important because the displacement of civilians in different areas, specifically in Africa, with different terrorist regions and internal political conflicts is very interesting because we have a big amount of people who do have sickle cell and trait in Africa. However, nobody is speaking about what are the consequences and what is the needs of these people when they are not only suffering from the disease, but they are displaced because of the conflict that exists. So to me, I always connect things, and to me, health is a human right. So it's really interesting. I'm always kind of learning and kind of putting the dots together and how I can support and put some ideas and some of my areas of expertise, educational areas of expertise in what I do. So thank you, Dr. Rowley, for the opportunity. Yeah.
So those were our intros. We are going to get started in just a couple of minutes. I always, history is really important. So some things, I like to kind of bring it all together. So at least in the US, 1910 is significant because that's when sickle cell was discovered by James B. Herrick, and who looked at these slides and called it elongated cells from this intelligent Negro, who was Walter Clement Noel. Walter Clement Noel came from dental student from Grenada, and went from Grenada to the US and then to Chicago to become a dental student for 3 years. And upon arrival, maybe a couple of months in, had a sickle cell pain episode, which they didn't know, but he was the first person that was written on in terms of a paper. Since then, there's been other writings. And so Walter Clement Noel never knew that he was written about, nor did he know that he had sickle cell disease. But we do know that he did die in his 30s, about 30s or 40s, without ever knowing. Then we go through history quickly. There was Linus Pauling who said, okay, in the 50s, this is a molecular disease. Then we kind of go up to the 60s and 70s with the Black Panther, who decided that this is really important. And so they did trait testing. And so as a result of that, Nixon, who did not have the black vote at that time, decided to take sickle cell as part of his platform. So it's kind of bittersweet because as a result, there's now national monies going into sickle cell, federal monies. However, that's all because of what happened with Nixon and having gotten elected. Then we speeded up to newborn screening. First state was New York in 1975. California didn't get newborn screening until 1990. And then all states by the year 2006. Speeded up right now. You're going to hear from Dr. Patel shortly on the pathophysiology, the different treatments, the different complications. So we are going to take just a minute break while the tech team brings on Dr. Patel. And so if anyone wants to take a quick break, I would say just a couple of minutes. We're then going to get into, like I said, the science, complications, the different treatments for sickle cell disease. So thank you.
She's on, but her video.
So do you have the trait to it? Do you have sickle cell trait or you have nothing sickle cell?
Oh, no, nothing.
How are your kids able to two of your children have it, or just have the trait?
Just to trade.
And I can order different percentage for people and prescribe it.
It's the
Thalassemia
part.
Yeah. Do they have any like sickle
They're
symptoms?
trying
that
to
show up?
connect her video and audio.
Well,
Dr. She's
Dr.
on.
Sheila would probably know
Except
more.
Bowel disease.
I've never seen anything.
Bowel disease.
Oh,
Well, we know it doesn't sickle, but we have a friend that actually had an episode, and he has trait, and it's the thalassemia trait. And he was doing some like backpacking in, I think Portugal or something, and he was like at a high elevation,
yeah,
and that triggered an event. So he actually had to have his spleen removed because of it.
okay.
So, but he only had the trait, so he didn't think anything like that could happen.
Did he have sickle cell trait?
I think he only had the thalassemia trait.
Because I never heard that happened with bowel disease.
Yeah, so I mean, I could double check on that, but I know he just said all he had was a trait. So. Kind of like Antoine has a
He
trait.
could have sickle cell trait and have that happen.
Okay, so maybe that's what it
He might
was.
have sickle cell trait.
Yeah, but I've never seen any symptoms at all with the kids. We only know because of the blood test.
Yeah.
Which was the issue
Yes,
with her mom.
yes, and Target.
Right.
Didn't know she had thalassemia till she had her go get a blood test.
Right.
And, oh, okay, that's where it came from.
Right, because that's just a carrier state. It's not connected to, you know, medical.
Sickle.
Yeah,
So,
it's the person that has sickle trait. You know, because they have sickle.
so the thalassemia is,
It's a whole different thing. It's a whole different abnormal hemoglobin.
Not related to sickle cell.
It's not related to sickle.
right, it's not, so, okay, they,
It's just when the person with sickle cell trait mates with somebody with a bowel trait. Because they can have a child with sickle bowel.
so the kids gonna be aware of it.
Yeah.
It's really to inform, you know, offspring.
Okay, then, you get somebody that has thalassemia, it could be issues, okay? Or sickle
Or
cell.
if somebody, if both parents have a bowel trait, they can have a child that has thalassemia.
It's almost like it's.
You know, which is another abnormal.
Yeah.
If only one parent has sickle gene, the other parent
Mhm.
has
Yes.
normal.
Because she's in a hotel,
Okay.
so I don't know if maybe they have Wi-Fi.
But the thalassemia is a tricky one because it has no symptoms, right? It's asymptomatic.
It's asymptomatic unless they have a child who also has bowel, and they wind up with a child
Uh,
Can you hear me?
we can hear you, Dr. Patel.
Perfect. Can you see my settings, my slides?
There they are.
Great. Perfect. Sorry that took a little bit of time.
No worries. Mary,
Hi.
there they are.
Okay, thank you.
No problem.
I like it.
No, sir.
I do too. Okay, Dr. Patel, you can go, you can introduce yourself and start.
Okay. Hi, I apologize there for that technical difficulty. I'm Ami Patel. I am a sickle cell doctor at UCLA. I'm internal medicine pediatrics trained, and then I did a 1-year fellowship at St. Jude Children's and the adult hospital there, Regional 1 and Methodist. And now I've been at UCLA for about a year. And so I've been tasked to talk about Sickle Cell 101. I'll try to make it as interesting and interactive as possible. So please ask questions. You can stop me along the way. And I'll have times to even stop as well to make it a little bit more interactive. And so I have no financial disclosures. So objectives, I'm going to talk a little bit about the statistics and healthcare inequities, the pathophysiology, complications, and then pain management. And I'm also going to talk about disease modifying agents. And so just talking a little bit about the statistics. And so sickle cell disease is the most commonly inherited hemoglobinopathy in the US. We estimate more than 100,000 individuals suffer from sickle cell, probably more. I think this data is a little bit outdated. Globally, sickle cell disease affects more than 8 million individuals, and the projected life expectancy is 54 in individuals with sickle cell versus 76 years with those without sickle cell disease. There is excess morbidity and mortality is tied with acute care utilization, hospitalizations, and readmission rates. So just thinking about sickle cell disease numbers in the US, and so it affects racial minority groups disproportionately. Sickle cell disease occurs among 1 out of 365 Black or African American births. Sickle cell disease occurs among 1 out of every 16,300 Hispanic American births, and about 1 in 13 Black or African American babies is born with sickle cell trait. And a high proportion of those individuals have Medicaid, around 46% in the US. So let's talk a little bit about some of the health equity that unfortunately a lot of our individuals with sickle cell disease suffers from adequate resources. And so adults with sickle cell disease, they're medically as well as socially complex. They experience health disparities. Upon entering adulthood, patients lose their primary medical home and health insurance. Many adult-focused providers have not really received sickle cell disease specific training. And so patients suffer from a shortage of specialized, knowledgeable providers. And there's difficulty in care coordination between primary and subspecialty services. Additionally, sickle cell disease has been historically less funded. So if you compare diseases that have less incidence in terms of population, less than half of what sickle cell disease have, they suffer from significantly less funding. So some of the challenges in the US, like I discussed, the lack of specialists who treat adolescent and adults with sickle cell disease, inadequate reimbursement for adult sickle cell that is preventive as well as team-based. A lot of these individuals require a multidisciplinary team, and unfortunately, the support for that team is not there in comprehensive centers. And in general, there's just few adult centers as well. There's a lack of knowledge and research, specifically on pain management, as well as preventing and treating organ dysfunction. And then lack of great transition from pediatric to adult subspecialty care. So I'm going to move on, and I'm going to talk a little bit more about pathophysiology. And so I thought this cartoon was a little bit funny. Frank was famous for his anti-inflammatory rhetoric as he put everyone to sleep. And so how is sickle cell disease inherited? It's an autosomal recessive condition. So both of your parents need to have trait, or one of them needs to have disease with another person having trait in order for it to be inherited. And so if both parents have trait, then you have a 25% chance that your son or daughter would be affected with sickle cell disease, 50% chance that they'll have trait, and then 25% chance that they will be unaffected. So what is some of the physiology in terms of sickle cell? So you have hemoglobin, and in hemoglobin A, it's composed of 2 beta globin chains and 2 alpha globin chains. And sitting in each globin, there's heme groups that have iron and hold on to oxygen. What sickle cell disease is that it has a mutation in that beta globin. And for hemoglobin S, the mutation is from a glutamic acid to valine. And so it's a one single point mutation that then causes an amino acid change. There's many different hemoglobinopathies, over thousands and more that are being discovered. The other big common one in the US is hemoglobin C. And so that's switching the glutamic acid to L-lysine. And then you also have beta thalassemia, which hinders the production of mature RNA. And so you basically, if it's major, 0, you're not producing any beta globin. And if you have minor or plus beta thalassemia, you're producing some beta globin. And so these different hemoglobinopathies can combine. So you can have hemoglobin SC, hemoglobin SS, hemoglobin S beta thal 0, S beta thal plus, SD, SE, many, many more. And then you can also have sickle cell trait, which is hemoglobin AS. So the first letter is what they have more of, so that's why it's AS. So how do you diagnose? You do a hemoglobin electrophoresis, and it will separate based on the size of that hemoglobinopathy. So C will be a different band, S will be a different band, and the other hemoglobinopathies will also be different bands. So what does this 1 point amino acid mutation do? It does a lot. So the way sickle cell disease affects the body, it can affect it more at the molecular level, where when you have this hemoglobin S mutation, what happens here on this left-hand side is that you start to have hemoglobin S polymerizing, so in a deoxygenated state. So if they're cold, if they're dehydrated, they're significantly exerting themselves, what happens is that these hemoglobin S starts to polymerize, and it forms these long polymers. And when there's many of them that occur and it starts to be irreversible, then it forms this nice sickle-shaped red blood cell, and that's what we call sickling of the red blood cell. What happens then at that point, you then have these sickled red blood cells that then end up having a shorter lifespan, and so then it ends up going into hemolysis. This hemolysis then causes inflammatory cytokines and other markers that being released. And then you also have where these red blood cells, the sickled shape, are going through vaso-occlusion. So they're sticking together in the capillaries, and it's also activating the endothelium. And so this, looking back at what I was explaining in terms of the polymerization occurring, and so you have this hemoglobin molecule here, the hemoglobin S ends up sticking together and it forms these long polymers. And then the pathophysiology of the vaso-occlusion, so these sickled red blood cells, they're all sticky, and they're sticking with different leukocytes that are being activated, as well as platelets, all these endothelial damage and the cytokines, and it causes this inflammation, and now blood flow is not able to go through, and this induces a vaso-occlusive pain crisis. And then same thing again, right? With the hemolysis, releasing of the free heme, you're activating the endothelial cells, you have superoxide free radicals, and that's causing these microvascular occlusions, deformities, and this is what's eventually causing organ dysfunction. And so it's really, really important that we identify the different type of hemoglobinopathy because the different genotypes can be on different ends of the spectrum. And so there are some individuals with sickle cell disease who are more of the hemolytic phenotype. And that's more common with individuals with SS or S beta thal 0, where their hemoglobins are lower, they're constantly hemolyzing, and they're going to have higher incidence of pulmonary hypertension, leg ulceration, priapism, stroke. And then you have those on the other end with higher hemoglobin, SS or S beta thal plus, which they have lower hemolytic rates, but now they have higher incidences of higher viscosity and vasal occlusion. And so they're going to suffer more from osteonecrosis, acute chest syndrome, as well as retinopathy. And so any questions about the pathophysiology before I kind of move on? I know that's a lot of nuances in terms of sickle cell disease. Okay, so we'll move on. So as we are advancing our medical care, we have progress in terms of reducing mortality. So you can see here in the black line, this is 1979. And this red line here is 2017. And so as you can see, as we've made strides in pediatric care, this mortality from age 1 to 4 has really reduced. And what's happening is that we're shifting this mortality further to the right, but we still have a huge peak in this early adult, young adult period from 20 to age 34. And we're seeing worsened mortality rates for adults as the years progress because of, again, this change from patients surviving in pediatric years, but really starting to have more severity and complications as they transition from the pediatric to adult care. It's really, really important to note that sickle cell disease affects every single organ. And so I always like to tell my patients, just, pain is the loudest, but sickle cell disease is a blood disorder. Blood goes everywhere in the body. So sickle cell disease affects everything. It affects every organ. And these are just a few of the complications. So in the brain, it causes strokes, thrombosis, hemorrhage, eyes, retinopathy, and other retinal damage, lungs, acute chest, pulmonary hypertension, spleen, functional asplenia, splenic sequestration, kidneys, nephropathy, and renal failure. In the marrow, it causes anemia. In the heart, thrombosis, heart failure, mostly diastolic dysfunction. In the biliary system, gallstones, hepatomegaly. Bone, osteonecrosis, as well as a higher incidence of osteoporosis. Genital, so priapism, infertility is another big. And then skin, leg ulcers. And then obviously the loudest symptom that we all know about, which is pain. One of the key slides that I like, and I actually adapted this from my mentor, Dr. Hankins, which if you see the complications of sickle cell disease, it really starts to accumulate with age. So in infancy, you have a very small amount of complications, infection, stroke, aplastic crisis. And then as you age into adulthood, as your sickle cell disease starts to affect more and more of your body, you start to get more and more complications. So I always really like to tell my patients that, not only does the adult care just have less resources, and you're also competing now with, instead of just sick children, you're competing with all of the sick adults. And so resources can be limited, but you're also just having more medically complex disease as well. And so how do we navigate this as your disease starts to progress and get worse? And so some big things that we do, right, is routine health maintenance. It's important that we're really, really screening all of our patients to try to see what are some of the complications and things that are occurring before they start to progress to be worse and worse. So in the pediatric years, if they have SS or S beta thal 0, it's important that we're doing the TCD stroke screening from 2 to 16 years of age. And then starting at 10 years of age, we're doing yearly ophthalmology visits to screen for retinopathy, making sure that all of our patients are seeing a dentist every 6 months as recommended, making sure that we're screening for nephropathy. And so doing urine microalbumin and creatinine ratios, and you can also do urine protein and creatinine ratios then yearly starting at the age of 10. Making sure that we're really prioritizing bone health. And so checking vitamin D every 6 months. And if they're low, making sure that we're doing adequate supplementation. A lot of my patients end up being on high dose vitamin D supplementation. Making sure that immunizations are up to date. So I know a lot of these patients, do see hematologist, and then they might forget to see their primary care doctor as well. And so making sure that all of their shots and immunizations are all up to date. So including pneumococcal at higher instance per CDC recommendations, Menveo, Menb, influenza, COVID, RSV now. So all of those need to be up to date. Other health maintenance that I always say very, very low threshold to obtain if there's any degree of concern. And so I always make sure I ask all of my patients on every visit, or at least on every annual visit, do you have any sort of dyspnea with exertion? And so can you walk up 2 flights of stairs without feeling short of breath? If they say no, then I order screening. So I start with an echocardiogram, but again, low threshold to order pulmonary function testing, 6-minute walk test, as well as screening for apnea and doing sleep study. Low threshold to obtain a DEXA scan. So in any of my patients who are postmenopausal, and a lot of them are postmenopausal in their 30s, I make sure I obtain a DEXA scan. In males as well, in their 30s, I end up just obtaining a DEXA scan. Concern for cognitive impairment or vascular abnormalities. So per the American Society of Hematology, they recommend that every individual have one baseline MRI or MRA brain with and without contrast. Screening ferritins. And so especially if they have a history of transfusions, we want to evaluate for iron overload. And so do they have persistent elevated ferritin? If it's greater than 1,000, I make sure I obtain an MRI abdomen without contrast. And there's specific protocols to look at iron quantification for liver and pancreas. And in those patients that are above, normally I end up saying 1,000 to 2,000. If it's persistent, I end up just starting on an iron chelator as we're waiting for this MRI to be obtained. And then if their liver iron concentration is greater than 15, or if I really do see some cardiac dysfunction noted on echocardiogram, then I obtain an MRI cardiac as well. If I ask all of my patients on annual visits about joint pain, and I'm making sure I'm obtaining x-rays and MRIs if needed to evaluate and screen for avascular necrosis. All right, any questions about some of this health maintenance?
Do I have to come in?
Yes, we do. One moment.
Thank you, Dr. Patel. Hi, it's Sheila Marchbanks. How are you?
Good, how are you?
I'm great. I don't know which way to face.
Face this way.
Okay, voila. Okay. I have a question as it relates with the complications where we sickle cell warriors have compromised immune systems. And as a result, being exposed to something just like a common cold, which say the non-warrior population can get over in days, it may take us a full month. So would that be considered a complication? I see it very rarely mentioned in presentations, but I know that I truly live with that reality almost continuously. So exposures to colds, flus, viral and bacterial exposure, and the inability to kit these things. Can you provide some input on that?
Yes, definitely. As your immune system is more compromised than most, getting a viral infection can take a little bit longer for your body to clear. So whenever you have a viral infection, what happens is that the symptoms that you experience is your body's response. And when your body is under stress and all of these other things, especially when you have sickle cell disease, that response can be delayed and also trigger other things. So it can trigger a vaso-occlusive crises. It can trigger acute chest when you have a viral infection. And so it's really important to try to prevent as much as possible, as well as making sure that your vaccines are as up to date as possible to try to prevent severe infections such as acute chest, and making sure that you get your yearly influenza vaccine as well as pneumococcal.
Absolutely. Do you think that that could be something that is included in presentations? Because I very rarely see that. Even as you know, we're encouraged to get our vaccinations and all, because let's say, for instance, in my case, I have a wonderful primary care doctor, Dr. Osborne Blake at the Sickle Cell Center of Excellence in Inglewood at Kaiser. So he's on top of all of that, you know, and the screenings that you've mentioned. Yet I find that even with all of that, if my grandchild comes around and they simply sneeze, I can find myself literally bedridden, even if I don't go in a VOC, bedridden with the symptoms of what a cold does, but then magnified because I'm a warrior and my immune system is reduced and my body is just not getting back. I cannot function. I can't get out of bed. And I'm telling you, it's literally 3 to 4 weeks for me to get over literally a common cold. And that means I'm almost non-functional in my home.
Yes, definitely. It could be included in presentations, and I think it's just an important piece to educate warriors about too, that when you get sick, your body may not respond as quick as someone without sickle cell disease.
True. Okay, and it impacts quality of life, you know, and all of that. So thank you for that. I do have a second area that I have a question about, and that is inflammation. What is, I very rarely see also any talk on inflammation. Could you share with us, Doctor? I find that my ankles and different parts, like wrists, blow up, and I'm dealing with inflammation. I don't know if it's a function of sickle cell or other aspects of my humanity, because you know, being a human living with sickle cell, everything can be just blamed on sickle cell. So I have found it in my life that sometimes, honestly, I would go into, you know, getting medical care, and I wouldn't even want to tell them I have sickle cell, because it seemed like that was the default. I had hearing loss, and yes, it was a function of sickle cell, but I didn't say anything about having sickle cell. Like, I lost hearing in my left ear, like literally on a snap. I went from hearing in my left ear to having compromised hearing. So I'm going around the corner, but inflammation. Could you speak to us about inflammation and as that relates to being a sickle cell warrior, if there is a correlation?
There definitely is a correlation in terms of inflammation. So as your hemoglobin is hemolyzing, so you have your sickled red blood cells, it hemolyzes it and it releases pro-inflammatory markers. And so that's a cause of inflammation. And that affects all of your organs, and it could also affect swelling. But additionally, inflammation isn't just from that pathway. I think there's a lot that's still being studied and being explored. And so I do know, and I've seen a lot of individuals with sickle cell suffer from an autonomic response to pain. And what I mean by that is that they can have a degree of medically what we call is like complex regional pain syndrome. And we don't fully know why. But as you know, individuals with sickle cell have had repeated vaso-occlusive pain crises. It's kind of triggered their autonomic and their nervous system to react to pain in a certain way. And it triggers their nervous system essentially to now create signs of inflammation. And so with individuals suffering from chronic pain as well, as we know, more than half of our sickle cell warriors who are adults suffer from chronic pain. They can also suffer from a degree of autonomic degree of inflammation from your autonomic nervous system.
Sure. And it's tender, like in the certain spots that I have, like my ankles or whatever. Not only is it swollen where it looked like a form of almost like elephantitis, and it goes up and down. It'll come and then reduce. but the touching, it's literally tender, like a raw tender sensation. So, yeah. So I do have a third. I said to Dr. Raleigh, would it be okay? I have a bonus question to ask. Boom, bitty boom. Sister Renee, would you like to share?
Dr. Patel, is there a blood test that we can measure the amount of inflammation in our body?
Good question.
That's a good question. Nothing specifically. So everything was a non-specific marker. So for example, ferritin also can be an acute phase reactant. So it's not just a level of iron, but it also can show degrees of inflammation, and platelets as well is another one of those. That's why a lot of warriors have elevated platelets, have elevated white blood cell counts, have elevated ferritins, not just beyond what we normally think those markers are. And so there's no one good test.
Okay, thank you. That was an excellent question, Renee. My bonus question. I really, another area that has been a quagmire for my health as well as I think other warriors, and that's neuropathic pain. So on your beautiful chart that showed all the different organs and systems that are affected by sickle cell, I literally have neuropathic pain almost in my entire body, that if I'm touched with a certain level of just pressure, it doesn't take much, that I feel like raw meat, as if I was bruised, and it's continuous. And so in addition to heart, AVN, and all the other items, Dr. Thomas Coates was the first one to diagnose me with neuropathic pain and explaining to us when we were down at Charles Drew University for our, at that time, our educational seminar, now called a summit. And he was like, Sheila, the opioids is not going to affect your neuropathic pain. And you know, being a warrior and being in pain and just being touched, I was like, yes, it does. You know, I didn't want to accept that, but now I have learned and been educated and opened up my mind and not in denial. What can be said and what can be displayed for us warriors that live with neuropathic pain, which is part of a chronic pain syndrome, but yet there's very little. The doctors even seem like the doctors I interface with, they seem almost like, oh yeah, you just gotta live with it. You know, I don't get a lot of answers or solutions. Yes, comfort in words and acknowledgement, but it literally took me 5 years to even get medical acknowledgement of it. And I had to go to a seminar that Nurse Pat's, I asked Kanapa, I always twist it, but that seminar where one of the doctor nurses spoke on neuropathic pain, and she helped me tremendously so that I can go in empowered with information and try to seek the answers, and also just acknowledgement that this pain exists in my body and it's not VOC pain.
No, and it's a very, very good point. And I think it's under talked about, and I think it's a big area of new research and interest in general, because it's a under-researched component. And we know that more than half of warriors suffer with a component of neuropathic or even just chronic pain that's beyond a physical aspect that you can see with avascular necrosis, and beyond, obviously, vaso-occlusive crises. As of now, I would say we treat neuropathic pain, unfortunately, with opiates, and we know that opioids can actually worsen neuropathic pain too. And so a lot of the things to treat neuropathic pain is that we have that exist is so either gabapentin or pregabalin. Some patients respond to one better than the other. The other thing that we chronically treat is an SNRI. And so using Cymbalta is the main one that we've normally have been using for neuropathic pain. And then if you're admitted with more of a neuropathic flare, ketamine and lidocaine infusions can also help with treating that. And I mean, TCAs, so any like tricyclic antidepressants also has been shown to help with neuropathic pain components. But really trying to understand how neuropathic chronic pain and vaso-occlusive crises feels in your body, because if you're hospitalized and treating with opioids repeatedly for neuropathic pain, you're perpetually worsening your pain in the long run.
Yes.
And so it's really important to understand and learn that, because, you know, people in the hospital, they say you're in pain, you know, mainstay treatment has always been opioids. And I think we've been doing warriors a disservice by just thinking about that.
Yes.
Another form of treatment that's been shown to help is cognitive-based therapy, as well as acceptance and commitments therapy as well, is another thing that's been shown to potentially help with neuropathic pain. None of these options are great, and there's no one recipe fits all. And so it's very, very individualized in what works for the individual. Additionally, with neuropathic pain too, is that this goes with the complex regional and autonomic that I was explaining. So your swelling a lot of times is directly related with that neuropathic type pain.
Dr. Patel, I want to tell you, this is the second time that I've heard your presentation. I believe you gave it for our physicians track at the summit or something. Excellent. I want to tell you, this is an excellent Sickle Cell 101 presentation. And I'm going to ask something. I shouldn't ask it publicly, but I'm going to ask, because this is the only format I have to talk to you. Is it, I mean, not the only format, but we're right here, right now. So my question is it possible to get a copy of your slides? Because much of what you're teaching, I can hear it, but I'm the type that, you know, Carolyn and Pat both know that I'm a researcher. And you're bringing to me knowledge and information that I hear you, but for me to know it for myself, I got to slow down and kind of look in a dictionary and do a little research so that I can understand this better. Because as a sickle cell ambassador, I really want to serve better. And if I'm educated more cognitively, I could help the world that God brings to me. So I'm just asking, is it possible, it may be proprietary, but if possible, so that I could use it as a tutorial?
Yes, definitely. I can share it over and send it. I think, I don't know if Major Effects Communication got the latest email of these slides, but if not, I can forward it over to you. And you could always reach me anytime.
I know, you're such a spirit. And in this, would it be too much to ask these 3 points that I've brought up, the compromised immune system and inflammation and neuropathic pain, that somehow, because you bless us with this presentation, if you can include something about that, and you wax eloquently on all of it, you know, so is there any way possible that you may consider putting these 3 in your presentation? I don't want to be, you know, presumptuous, but I think others may have the same questions.
Yes, let me write that down so I don't forget.
Okay, you want me to say them again? Oh, no.
No, I got them. Just
Did you say that?
No, she can't.
Okay, I got it.
So if it's okay, we're gonna keep, because we have.
I'm out. Am I sitting there?
So I'm sure there'll be another break. And so Dr. Patel, you can continue.
perfect. I don't know if, do I have to read? Okay, you have to, perfect. Thank you. So I'm just going to switch to talking about some of the severe complications of sickle cell disease. And so, as we know, stroke, so cerebrovascular accident, are at a higher risk in individuals with sickle cell disease. So in general, children suffer more from ischemic stroke. And so some of the symptoms they might experience is sudden onset of hemiparesis, aphasia, which means they can't speak, facial droop, or occasionally they present with a seizure. Adults more commonly have hemorrhagic stroke, so severe headaches, altered level of consciousness, seizures, speech problems, and or paralysis. And so if we ever suspect and we have any degree of focal neurological deficit, making sure that we're getting a CT scan stat, followed by an MRI, MRA brain, and then initiating exchange transfusions emergently. And if exchange transfusions for some reason are not available at your institution, or there's going to be a delay, making sure you're doing a simple transfusion until you can transfer over to a place where you can get an exchange or a manual exchange if that could be done at your institution. Acute chest syndrome. So for me, I always say acute chest syndrome is very similar and just resembles pneumonia because the nuances and the differences are very minute. And so for most people, I just like to say pneumonia and acute chest, think the same thing because you should treat it aggressively. And so it's signs and symptoms of a lower respiratory tract infection, and you see a new pulmonary infiltrate on chest x-ray. There's increased risk when you're hospitalized for a vaso-occlusive crisis, or you're hospitalized in general after any surgical procedure, or any individuals with a prior history of acute chest syndrome or asthma. And so making sure you're getting the chest x-ray, you're monitoring their oxygen levels, you're getting a CBC and a reticulocyte count, and then obtain blood cultures. And then treating acute chest with antibiotics, so IV cephalosporin and an oral macrolide, making sure they're having adequate respiratory support. Considering a simple transfusion if hemoglobin concentration is less than 1 gram below their baseline, and if it's less than 9 grams. And then if rapid progression, making sure that you're performing urgent exchange transfusion. And then encouraging incentive spirometer while they're awake for management and prevention. And so every single patient with the vaso-occlusive crises who's in the hospital should have an incentive spirometer by their bedside to prevent from acute chest syndrome, and encouraged to use it 10 times while they're awake per hour. Priapism, painful erections, it affects about 1/3 of boys and men in their lifetime. There's multiple self-limited episodes that may be a harbinger for more than a 4-hour episode. So treatment, so if it's greater than 4 hours, to initiate oral and IV hydration, IV analgesia, and making sure you're doing an urgent emergent urology consult. And then if refractory to aspiration, then can consider exchange transfusion. Multi-organ failure. And so that presents with rapid and unexpected deterioration. So it typically occurs in adults in settings of severe vaso-occlusive crises. Signs, so you have fever, rapid decline in hemoglobin and platelet count, non-focal encephalopathy. And so you diagnose it with 2 out of the 3 severe organ dysfunction, so the liver, lungs, and or kidneys. Treatment is exchange transfusions or simple transfusion, and then making sure that you're doing supportive care. So CRRT, oxygen, whatever supportive care that's needed. Splenic sequestration. So sudden enlargement of spleen with reduction in hemoglobin concentration by at least 2 grams below baseline value. And so it's consistent laboratory findings. So you'll see an elevated reticulocyte count, you'll see circulating nucleated RBCs, and then decreased platelet counts. And making sure that you're palpating the spleen if you can. It's a little bit easier in pediatric patients. So ultrasound can be useful if you can't feel it, and looking at the spleen size. You treat by transfusing no more than 5 mils per kilo if they're having worsened anemia. IV fluids if they're hypovolemic, and then especially if it's the second time that they've had it, consider a splenectomy. So hepatobiliary complications. You can have acute cholecystitis, acute choledocholithiasis, biliary sludge, acute hepatic sequestration, acute intrahepatic cholestasis. And so we kind of, for the most part, the biliary stuff, so acute cholecystitis, their biliary sludge is done similarly to the rest of the population if you suspect and diagnose it. What's different specifically in sickle cell disease, so acute intrahepatic cholestasis, so it's characterized by sudden onset of right upper quadrant pain, increasing jaundice, progressively enlarged and exquisitely tender liver, and you'll have extreme hyperbilirubinemia without common bile duct obstruction or cholangitis. And then initial workup is you get a CBC, retic, you get ALT, AST, and total indirect bili. You get a right upper quadrant ultrasound, and then you consider an ERCP if choledocholithiasis is suspected. And then treatment, like I said, anything gallbladder related, you do your typical management that you would do for any patient with gallbladder related issues. And then for acute hepatic sequestration and acute intrahepatic cholestasis, perform simple or exchange transfusion. All right, so switching gears to pain management for vaso-occlusive crises. And so I've been in pain for a few days and the medication isn't working. So now just a reminder that patients don't want to be in the hospital. They don't want to go to the horrible place, but they're going because this is their last resort and medications at home are not cutting it. And so here's a typical profile of events that happen when individuals come in with a painful vaso-occlusive crisis without any other complications. And so overall, they start to have some small degrees of pain, then it starts to increase. And you start to have other degrees of markers that you start seeing. So you start having elevated, or you can. Not every patient's going to present the same way, but you can see some degrees of inflammation potentially on their labs. But again, it's important not to look at labs and vital signs because every patient will present differently. And so it starts to go up and then it hits the steady state values and you start having more and more pain to the point where there's no return. The pain won't go down. And then you end up having this plateau. And this plateau typically happens from day 3 to 7. Patients typically present to the hospital on day 2 to 3 of already trying their oral medications, and they're kind of presenting most times when they're on this part of the vaso-occlusive arc. And then you start giving them their typical pain regimen, and then, ultimately on day 5 to 7, their pain starts to improve and starts to go down. And so it's really, really important that you treat patients aggressively up front to try to prevent the delay and an earlier resolution of their pain. And so the challenge is that as you start getting older, your vaso-occlusive arc is no longer the same. And so what happens is that, you have your initial phase, your established phase, your resolved phase, but as you start developing more chronic pain, as you get older, no longer are you returning back to your baseline. This baseline is going higher and higher and higher. And chronic pain starts to emerge really more in that adolescent and young adult years. So this is just a good resource for everyone to have. And I encourage everyone to download the American Society of Hematology app. And it kind of goes over different guidelines. So it talks about cerebral vascular disease, cardiopulmonary and kidney disease, transfusion support, management of acute and chronic pain, and it also talks about stem cell transplant. And so acute and chronic pain and sickle cell disease, this is what I'm going to focus on. Acute sickle cell pain can happen as early as 6 months of age. It's the most common cause for ED visits and admissions. Management of pain affects further coping. So it's really important that, as we continue to progress in our society and hopefully reduce more and more bias, it's really, really important that the way we treat this patient today can affect the way that they either even present to the ER, the way that they cope with their pain in the long run. And so it's really important to understand how every single time we are interfacing with an individual suffering with pain, how much it's going to affect them long term. Acute pain typically affects long bones. A lot of times it can affect low back, but it can affect different areas of an individual. And so the scalp, face, and pelvis can also be a site of pain. It's really important that when someone presents with pain, that we just don't assume it's always vaso-occlusive crises, and that we're considering other sickle cell disease complications, as well as other non-sickle cell disease complications too. And so treating all pain the same is like treating all forms of anemia with the same approach. We really need to determine the etiology of pain. And so what are the recommendations for acute sickle cell pain management? So we recommend rapid, so within 1 hour of ED arrival, we recommend rapid analgesia and frequent reassessments every 30 to 60 minutes. And if non-IV routes are available because it's either a challenging vascular access or for whatever reason, making sure that, we're optimizing subcutaneous or intranasal if available. Making sure that, knowing that some individuals will have hard vascular access, and so making sure that ultrasound is also available. The other recommendation that they have, 1B, is tailored opioid dosing based on their baseline opioid therapy and a prior effective therapy. And so having individualized care plans in every chart is really important, and making sure that those pain plans are discussed with the patient on an outpatient, non-stressful setting so they know exactly what to expect every single time they go into the ER. So this is kind of what I had mentioned. So how should we approach pain? Believe your patients that they are experiencing pain. Not all pain are vaso-occlusive crises. Utilizing the individualized pain plans. If you increase opioid medications, making sure you talk and have a plan to decrease it. Maximize adjunctive therapies, and then aggressively treat pain in the first 48 hours, and then involve your patients with a taper plan and plan to wean depending on patient's response, so anywhere from day 3 to 7. And if pain is lasting longer than 7 days, really evaluating what else potentially could be contributing to pain. So inpatient pain management, it's really important. When admitted, we're not changing plans overnight. We're defining how changes should be monitored and adjusted with the patient. We're avoiding swings of medication, so trying to add on a long-acting medication. Having a standard protocol and note in individual patients. So if you're deviating from the protocol, making sure you're listing the reason why. And then, like I said, aggressive in the first 48 hours, involve patients in a taper plan, try to wean by day 5 to 7, and start weaning the short-acting IV opioids first, and then the scheduled, and then the non-opioids. And so opioids in general have been the mainstay treatment of acute pain related to sickle cell disease. But this is kind of what I was talking about before with Sheila, is that some patients may not respond to opioid therapy alone. And so trying to do multimodal methods for analgesia, and that could include ketamine and lidocaine, especially if you suffer from neuropathic pain. Pathways to reduce opioid burden would provide non-opioid analgesics to treat acute pain, with the goal of reducing the total dose and duration of exposure while maintaining and improving analgesia. And then there has been a greater understanding of the complex nature of pain. So better definitions of acute pain, chronic pain, and acute on chronic pain have emerged as well. And so, trying to stay distracted, doing other things while you're having pain has been a mainstay of what a lot of warriors have done. But again, at 2 a.m., when you're trying to sleep, is when it's hard to distract yourself at that point. There are 3 common types of pain in sickle cell disease. You have the acute intermittent pain that typically occur with vaso-occlusive crises. You have chronic daily pain, and then you have acute on chronic pain or chronic pain flares. And so the AAPT had defined chronic pain specifically in sickle cell disease. And so this is a lot of words on this slide. I'm just going to summarize. The main thing is that in a 6-month period, you had more than half of your days that you experience pain. If that's the case, you pretty much have chronic pain. And there could be no explained reason why you have chronic pain. It could be that you have avascular necrosis, or you have something that you can tangibly see. You have pain from leg ulcers, or you have pain from any other method that you can see, or you have a combination. It's like, yes, I have pain from my leg ulcers, but I also have pain all over my body, or I have this burning type of pain that's neuropathic pain. And so there's multiple different types of chronic pain that you can have and suffer from. This is, it was the Pisces study from Dr. Smith, but they basically had 232 patients create daily pain diaries. And this is how they started really realizing how many sickle cell warriors suffer from chronic pain. And so pain on those diaries reported on 56% of the days. 29% of patients had pain on greater than 95% of the days. Only 14% had pain on less than 5% of the days. And then pain crises occurred on 12.7% of the days. And a visit to a physician or hospital was 3.5% of those days total. And so healthcare utilization is not a great predictor of pain crises. So there's a lot of non-opioid pharmacological recommendations for chronic pain. So Cymbalta, which is an SNRI, tricyclic antidepressants, and then gabapentinoids, so pregabalin and gabapentin. All right, any questions about any of the complications with sickle cell disease?
Go back to questions from the beginning there. Could I ask you questions about the beginning I wanted to ask that I've been able to ask yet?
Yes.
On the data for births, is there any data on Latinos carrying sickle cell trait?
Sorry, I didn't quite hear that.
Is there any, you mentioned on a slide with birth rates and Latinos, 1 in every 16,000 Latinos are born with sickle cell disease. Is there any data on Latinos actually being sickle cell trait or carriers of the disease?
Yes, I can send you that information later, but it's, I think, 1 out of every, I'm trying to, I have that data somewhere.
Yeah,
There
that's
are
fine.
in
No,
terms of the trait, yeah.
it exists. Like, we're starting to learn more about different groups of people being affected by it. So what we found in my organization is we're trying to get that information out because everybody just thinks it's a black disease and it's really not. So we're trying to get as much information about that as possible. If there's also any data on Caucasians carrying the trait, we, interestingly enough, in our organization have had 2 volunteers who are of Caucasian descent actually have the trait themselves. And it got traced back to Mongolian descendancy, which we found to be fascinating. So if there's any data on that, that would be cool to know that as well.
Yes, I'll try to look through and see. I know I have the Latinx information and data in terms of how many patients in California, especially, are born. But I will send that to you. I know in fellowship I had 3 patients who were blue-eyed, blonde hair, so it is common.
Yeah, I know. And people don't, yeah. So we can touch base. I can also reach out to you and we can figure it out. On one of your other slides, I saw the mortality rates that you were talking about from the 70s, the 90s, and the 2000s. I noticed in the 90s, a lot of patients were dying anywhere from 25 to 30. That green line really jumped up in that time period. Is there any explanation why in the 90s there was that spike? And is there any way that it could happen again? Is there any preventative things that we could do to keep that from happening again?
Yeah, I think the main thing is that there were so many advances in pediatric years, and everyone was focusing on pediatric years. And so in the 90s, when they realized that this population is aging, is when that started to emerge. We didn't have the adult resources at all. And so that's why there was that huge spike in that young adolescent and adult group. Now in like 2017, it's slightly shifted a little bit more with slightly better resources for the adult, but there's still a ways to go.
Right, that makes sense. Yeah, I got some more questions, but just in terms of what we've been talking about recently with the splenic secretion, I don't know if I'm saying that right. Sequestration. Have we seen a lot of cases as well with people who have sickle cell trait experiencing that? Because I do have a friend that did experience that, and they needed to have their spleen removed. And I was just telling them the story about that. So,
In terms of sickle cell trait, we're still trying to learn more about what that fully means. And so they're, creating a huge database with individuals with sickle cell trait called AUNT, that's nationwide, to try to fully understand more. A lot of times I have seen a couple that end up having sickle cell disease, but then they have other complications and comorbidities too that could also explain the splenic sequestration. And so it's really hard to say, is this because of trait, or was that just an incidental thing, or was it because of X, Y, and Z that also caused them to have splenic sequestration? But it's hard because there's no great data.
right. Cool. Thank you.
So before you leave us, you know that my focus is always on the pain, because that's the thing that the patients talk most about, and they talk about the treatment they receive from individuals related to their pain. Because even when the doctors order pain medicines, they don't always get their pain medicines in a timely fashion. And so they have these prolonged periods of time before they receive the pain medicines. And then when the pain medicine doesn't work, then they're judged because, we gave you your pain medicines, but you're still complaining about pain. So is there something we can do with that, number one? Can we really mandate that patients receive what they're supposed to get when they're supposed to receive it? And then the other thing is, you were talking about the different types of pain. I remember years ago, we used to do cocktails for pain. So we just came up with how we could use certain medicines for that particular patient to ensure that they got the pain relief that they needed. Everything seems like there's an order written, and that order looks just like the order for the other patients, So there's no real trying to figure out exactly what needs to happen for an individual. It's not an individualized pain protocols. It's, okay, we're gonna give them a dose of this. We're gonna give them a dose of that. And the patients are sharing that, that there are things that work for them. But, and I can understand that we're trying to move away from certain things because of all of the concerns about different types of pain. But is there any research being done to identify whether what we've just decided to start using is working for patients, as opposed to what patients are sharing with us works for them?
And so we're trying to, I think, try to do as many multimodal methods in terms of pain relief. And so in people's individualized pain plan, I try to talk about other methods as well, in addition to their pain, and to try it out. Because sometimes, obviously, doing Tylenol alone, treating a vaso-occlusive crisis is not enough. But doing it in addition to X, Y, and Z therapy, sometimes it's really hard to say if the Tylenol is, could be adding a degree of pain relief that, we don't fully know. It's really hard, though, when we're doing these studies, how to isolate, is the Tylenol providing relief? Because we can't treat a vaso-occlusive crisis with Tylenol in itself. I don't know if there is any studies, though, and that's a good point. Maybe in addition to standard IV opioid care, seeing if there's any changes in length of stay when we do a multimodal approach in general. So that could be something to be looked at. In terms of the reassessment and pain, the medications not being given, it's something that's a problem at almost every ER, including UCLA. And so I'm trying to come up with better methods in terms of that. But I know, the busyness of the ER, and then people not fully understanding that the importance of treating it aggressively initially is part of the problem. But my big hope is that we can start coming up with better standardized protocols to move it out from the individual provider and more into a standard method. So what I'm trying to work on and trying to get approved is that when they come into the ER, you see that they have a pain plan. And so instead of doing reassessment one dose at a time, why don't you order Q3 dosing? And that if the pain level is above a certain level, the nurse can then order or can administer that PRN medication after 30 minutes to an hour. And so working on that, and then working on, instead of, the ER puts a bed, request in, now it's up to the hospitalist to start admitting the patient. The problem is that the hospitalist can also get 10 different admission calls at the same time, and them getting down to see the patient a lot of times can get delayed. And so can we have the ER doctor now order, if there's a PCA system in place, order it? Or when the admitting doctor does get that, instead of them reevaluating and reassessing the patient, because they may not have time to do that right away, can there be a standard protocol as soon as they get the pain or they get the admit button, that they just go into the chart and they put in the PCA based on the pain plan, to try to prevent those delays? A lot of red tape with a lot of these things, but that is the push.
So are there any mandates for hospitalists to know sickle cell disease, or to take a course on sickle cell disease? Because I know that all the patients that come in who experience hospitalists all have the same complaints. And I don't know whether that's lack of knowledge about sickle cell disease and a management of pain, or what it is exactly, but almost every patient you talk to who encounters hospitalists encounter people who have judgment and who will, okay, I'm gonna give you one dose and that's it, and then we're gonna do this. So is there any, in place education of hospitalists? And is there any way that patients can report, experiences they have with hospitalists to move us in the direction, ensuring that someone takes a look at the fact that lack of education about sickle cell disease and management of their description of their pain is regarded, and people with sickle, how do we change the narrative for people with sickle cell disease so that everybody doesn't think they're drug abusers, drug seeking, they only come to the hospital for drugs, because the last thing the patients that I know want to do is come to the hospital. So how do we do
Yeah,
this?
no, I mean, that's a great point, because even in ACGME curriculum for hematology, there's no mention of sickle cell disease, which is crazy. So even the people who are blood specialists, there's no mention of sickle cell disease in their curriculum. So this needs to come, I think, a lot from the higher, for example, I just got a message when I renewed my California license that I did not submit a CME credit for opioid use disorder and addiction medicine. And so that's a mandate coming from the California state that you need to at least submit 1 hour of CME credit in regards to addiction and opioid use disorder. If maybe from the legislation we can have something similar where there needs to be a mandate 1 hour for sickle cell disease for this next renewal cycle, then that might be something that can help.
They do that in nursing renewal as well. They have certain areas that have to be addressed. You have to take a course that covers that area, but no one does anything that makes people gravitate toward getting more information on sickle cell disease. Everybody just, they treat people with sickle cell disease, but if you really talk to them, they will tell you that they don't know anything about sickle cell disease, and it seems like we should be pushing for putting something in place that mandates that they have to know something about sickle cell disease, because the number of people affected by it is quite a large number.
Yeah, and I think this is a good point for, even just changing some of the CME curriculum. I mean, at my small, institution level, I'm speaking at the next hospitalist meeting on November 12th. But again, that's small institution level wide. And so I think it takes time, because even at my institution, there's over 150 hospitalists.
Yeah, they're taking over the world.
So, Dr. Patel, you have 20 minutes.
Okay, yes. All right, so next I'm going to talk about just disease modifying agents. And so this is just a quick schematic of the pathophysiology. So this is at the DNA level, the protein level, with the polymerization, sickling, hemolysis, and endothelial adhesion, and inflammation. So these are all different levels of targets. And so gene therapy, not quite fully at the DNA level, but sort of at the DNA level. I'll speak a little bit more about that. Then hydroxyurea affects, and I'm actually at this Fulcrum meeting right now in Dallas, but this all affects at this particular level. Then you have RBC sickling. So this is where Oxbryta was affecting, and then hemolysis, which is L-glutamine, and RBC health, and then endothelial adhesion, which is crizolizumab and P-selectin inhibitors. So just a quick thing about disease modifying agents. So hydroxyurea, first line, many different mechanisms of action, increasing fetal hemoglobin, decreasing inflammation. The goal is to titrate up to maximum tolerated dose, because it's very dose dependent. Clinical shown endpoints. So it increases the hemoglobin at non-myelosuppressive dosing, decreases pain crises, acute chest, decreases hospitalization, decreased organ dysfunction, which is improving persistent microalbuminuria, splenic dysfunction, twitching to hydroxyurea, so the whole helping with stroke prevention stuff, neurocognitive delay, and then pulmonary arterial hypertension. These are some of the clinical endpoints, and it affects a bit more. But since hydroxyurea is the longest one that's been out, we know of a lot of the different improvements in prevention and organ dysfunction. Endare or L-glutamine, inhibition of oxidant stress and inflammation. It improves RBC health. And so in this study, the clinical outcomes at 48 weeks, it decreased pain crises by 25%, reduced frequency of hospitalizations by 33%, and then decreased acute chest syndrome. Crizoluzumab, P-selectin inhibitor. So there's been many different trials. For the SUSTAIN phase 2, it really decreased median time to first and second pain crises and decreased hospitalization frequency. In the STAND phase 3, which was more of a global trial, there was no significant difference in pain. And then the SPARTAN phase 2, it's showing a reduction in priapism episode. What I like to say with crizoluzumab is that it affects, I would say, about a third of our sickle cell warriors really well with helping decrease their pain. The other 2/3, it either has no significant effect or may actually worsen their pain. Oxbryta, voxelotor, which was just recently recalled by Pfizer, it inhibited the intracellular hemoglobin S polymerization. So what the clinical outcomes that they saw was that it improved hemoglobin concentration and decreased hemolysis. Reasons for recall, I would say there's 3 main ones. So one is that it inhibits the intracellular hemoglobin S polymerization. So it really binds to it to prevent the polymerization and preventing this RBC sickling. And so what happens is that it also bound and increased oxygen affinity. The problem is if it bound to it too well, that when the red blood cells were circulating the body, it wasn't actually releasing the oxygen at the tissue level. And so there was concern for tissue hypoxia, which then they're relating to this imbalance of pain episodes. And also globally, when they were doing trials, there were many fatal deaths in relation to malaria. And so the 3 FDA approved therapies, or there's technically, Oxbryta is technically still FDA approved, but the 3 therapies that are available, hydroxyurea, and this is where it's decreasing pain crises, decreasing hospitalization, increasing hemoglobin, decreasing hemolysis, and decreasing transfusion needs, as well as acute chest, and just improving organ function. L-glutamine and crizoluzumab. L-glutamine really helps with pain, hospitalizations, and acute chest. Crizoluzumab, in about 33%, helps decrease vaso-occlusive crises and priapism. Chronic transfusions, simple or exchange. So indications, stroke prophylaxis or abnormal TCDs, any history of significant acute chest syndrome, which is a possible indication. Again, this is questionable. Pregnancy depends on the individual. Pulmonary hypertension is another possible reason for chronic transfusions, and then severe vaso-occlusive episodes that are occurring at a higher frequency. Okay, so moving over to gene therapy. So there's 2 that are FDA approved, Casgevy, so it's a CRISPR-Cas9, Vertex, and then Lyfgenia, which is a lentiviral gene addition, so Bluebird Bio is the company. So gene therapy for sickle cell disease, it's really important. The key takeaway is not all of them are the same. And so there's many different big categories for gene therapy. Gene addition, gene editing, and base editing. There's also many different targets for sickle cell disease. So one of them is increasing fetal hemoglobin. The other one is increasing normal hemoglobin A expression. And then the last thing is correcting the mutated sickled beta gene. So like I said, there's so many different companies, so many different types of gene therapies that are all being developed. And so not all of them are the same. So it's really important to know which gene therapy you're getting and knowing the endpoints. So overall gene therapy, you identify the individual who's a good candidate for it. Once you identify, you do all the screening that's required. You start doing exchange transfusions. Then you harvest their bone marrow and their stem cells. You bring that to the lab. You might have to do many harvests to make sure you have enough stem cells. You edit the cells, and then after 3 to 4 months of that whole process, you can then do a myeloablative conditioning regimen with busulfan, so chemotherapy, and then give the edited cells back. And so what does gene addition or lentiviral vector mean? And so I adapted this from Dr. Sharma's slides, but I thought it was a really easy way of interpreting it. So I love going to Disney World. And so instead of instead of going being spelled wrong and world, instead of changing any of that, all you're doing is inserting how it should be spelled. So going and world. And so the Bluebird Bio study, and this was the data that was presented or that was published by Dr. Cantor in the New England Journal of Medicine in 2022. There's a lot more data after this, but they treated 35 sickle cell individuals in Group C. They followed them for up to 38 months. And what they found was that there was near pancellular expression of their
No,
There she,
yeah, they know. Turn it up or down.
reduction in vaso-occlusive events. Gene editing, so CRISPR-Cas9. So you're basically just putting nonsense into it. So you're not fixing anything, you're just putting nonsense in order to kind of knock out the production. And so what Casgevy or Vertex does is it knocks out BCL11A. BCL11A is in charge of repressing fetal hemoglobin. So you essentially increase fetal hemoglobin. And this study, they basically showed that there was a significant increase in fetal hemoglobin. Some of the technical issues related to gene therapy is the collecting of the stem cells. A lot of times it takes several collections, the efficacy of editing, and then off-target effects, and then pre-bone marrow conditioning toxicities, ethical challenges, and then financial considerations. And so long-term effects, we don't really know how long this is going to last. It's transformative, it's not curative. In the Bluebird Bio study, 2 patients developed myelodysplastic syndrome when they had 2 gene deletion alpha thalassemia trait, and then the theoretical possible risk of leukemia or other cancers in the future. And so overall conclusion, so sickle cell disease affects every organ system and a comprehensive approach is needed. Don't assume every sickle cell pain is a vaso-occlusive crisis. Treat vaso-occlusive crises aggressively initially and then can wean. More than a half of adults living with sickle cell disease suffer from chronic pain. And then start disease modifying agents and other possible therapies based on clinical targets and the needs of your patient. And then thank you.
Thank you. Excellent.
Yeah.
It looks like we have a few minutes. So does anyone have any questions? We have a few minutes before Dr. Caroline's on.
Yes, one quick question on the gene therapy. Not the gene therapy, the Oxbride, those therapies, modifying therapies. What are the side effects? Are there any common side effects that you see across the board? Or does each one provide its own unique set of side effects?
In terms of why it was recalled or in terms of?
No, not Oxbride, but those treatments that we were talking about in general.
Bluebird and, no.
the
Modifying therapies, is there a general side effect for all, or do they tend to have their each individual side effect?
They all have their own side effects. And it's also dependent on the patient, just like any medication. The side effects differ. Most common side effects are going to be the GI upset and diarrhea.
Thank you. Anyone else with questions?
She's going to her meeting.
Can we have a bio break? A bio break.
She wants a bio.
Okay, we are. Dr. Patel, thank you.
Thank you. Sorry, I'm like,
Okay, thank you. Okay, everyone, thank you. So we have 5 minutes before we start with Dr. Caroline. So tech team, if you can let Dr. Caroline know, we'll start right on time at 2:30. So if you want to just we'll just do our 5-minute break right now. Thank you. Dr. Caroline's on? All right. So we're going to get started with our second presentation. Dr. Caroline is a little bit delayed. And hers is on health disparities. And that has to do with the ER. And her, as a ER doc, there's something that came out, goodness, a few years back now called EDSC3. And it's an attempt to get emergency room doctors on board with proper evidence-based ways to manage and treat people with sickle cell disease. The other part of that, which I'm going to talk about, and I'll turn it over to Nurse Pat, is that there were some landmark articles that came out, one in 2020 by Patrick McGann and Alexander Power Hayes, excellent, called When Action Speaks Louder Than Words. It's an excellent, excellent article from the New England Journal of Medicine. And it just lays bare about the institutional racism, systemic racism, health disparities, the fact that cystic fibrosis and other rare diseases get 10 times more dollars than sickle cell disease. That in terms of management, that management is poor. So in the back of their article, they actually say what you can do. These are things that you actually can do. I highly recommend that particular article. The other one is Jeffrey Glassberg out of Mount Sinai in New York. And so I always reference his article because he talks about, as Dr. Patel was sharing, evidence-based, as soon as the person comes in, what you should do. And you give them what they ask for within the hour. You check every 30 minutes to 60 minutes and check to see how they're doing, and then you hit it hard. Unfortunately, what we find is that it is the complete opposite time and time again, the complete opposite. So not only are they not seen in the first hour, if a patient says, I take 2 milligrams of Dilaudid every 2 hours, they're given maybe 0.2 milligrams every 3 hours. Then it goes up to maybe 0.5 milligrams every 3 hours. That's ridiculous. So we're left advocating to get them to see that that's not even evidence-based. It's not really humane. And you're going in the wrong direction because patients wind up having longer stays because they're little by little going up versus just giving them what they want. And again, time and time again, what's the problem? They're not believed. Nurses will say, I've heard it, I do not feel comfortable giving the person that much medication, even though it's already been ordered and ordered timely. And so the nurse will say, I don't feel comfortable, and so therefore the person doesn't do it. So these are what we are going to be talking about today, and Dr. Caroline, when she comes on, about what she and her group are attempting to do to change that landscape. But part of it is that these emergency room doctors need to sign on. So that's what we're here for, to share that these groups do exist. They do provide training. And so it's EDSC3, American College of Emergency Room Physicians, ACEP. And so this is what they're doing, trying to change the landscape of how things are currently being done versus what is evidence-based to be done.
Okay.
So we can talk about the health disparities.
Yeah.
So we have to get here so they can see.
Allergies? What's that?
No, I do have some
And
dust
so-
allergies.
And this could be, I actually kind of prefer this to be a discussion as well. Because I think by brainstorming and talking out loud, maybe we can try to come up with ways to change the landscape, even if it's hospital by hospital. Something has to be done. It can't continue to be done the way that it's going right now.
Yeah. So I think it's really important for us to, first of all, kind of share, because all of us know people with sickle cell disease, and all of us have had the opportunity of talking with people with sickle cell disease about their experiences. And so I just think just sharing some of the experiences that you've had as you spoke with people with sickle cell disease and what their concerns were, and what it left you feeling after speaking with those individuals with sickle cell disease. And did you think that the person was just a person that complains about, about everything? Did you think it was somebody who genuinely needed some help and was not given help? Do you think there are ways of changing? How do people look at people with sickle cell disease? So we'll just start with talking about how people within the healthcare system and even in families sometimes look at people with sickle cell disease, because I think that's important to really talk about. So floor is open.
So I have two anecdotes for that. One patient, Rochelle, she is a very intelligent person, articulate person, headstrong. And I think what happens then when she went and told us she shared a lot of stories with us, me in particular, because as you know, being a scientist, we ask a lot of questions. So I'm always asking a ton of questions. She told me in particular this one time she went into the ED and said, presented the pain plan, everything. She thought they were all set, ready to go. And they had switched out doctors because she had been going to a consistent clinic hospital. So they had known her at that point. But she wasn't aware of the fact that there had been a changing of the guard and there was a whole new shift of doctors that had come in as nurses as well. So some of them were not privy to her because she luckily had been able to stave off having to have such crisis that she had to go to the ED. So when she came in with her pain plan management and she presented it to the doctors, they literally just looked at her and just threw like the page away to a side and just went into their own protocols as if they know better than their patient, and they just adhere to the strict practices that they do, whatever the protocols are at that point in time. In which case, Rochelle then started to, in her eloquent way, describe exactly what was going on to her, why the pain plan existed in the first place, what she had been doing, naming doctors, naming nurses that had been working there before, giving literally her own patient chart to them verbally. And they still looked at her like, she's talking too much, you don't know what you're talking about, you don't have the same education as I do, so why are you thinking you're at the same level as I am? Is the way that she was projecting the story to me. And just knowing her, the passion that she has, I could easily see how someone could be intimidated, someone who's new, someone who's fresh out of boot camp maybe, they don't know the ins and outs of life yet, and they think just because they have some degree or they've gone to Johns Hopkins or the Harvards of the world that they know better than somebody who hasn't gone there, which I think is a huge travesty in and of itself, which is another thing that I have problems with this country above other things. But it just seems to me like certain people are just pegged a certain way, regardless of what skin color they are. And, personalities, just very big personalities come off wrong to very inferior personalities, right?
That's right.
People with, that don't have the same moxie and confidence as others tend to hide behind whatever they can in order to make themselves feel more equal or level, whatever you want to say. Secure, thank you. So in that sense, I think she was just misconstrued personally. In which case, we have to also change that from a doctor healthcare perspective, because just because a person's, a certain way, like, oh, they're too much, or they got, they're headstrong, or whatever other words I want to say, as long as I'm staying above board with the language that they use, right? I think we should kind of go away from that and actually treat the patient, as a body. They are in pain, they are in suffering. That's what we need to go for. Yes.
So I think that even though many CBOs provide education, that education is a double-edged sword, because we want you all to be empowered and to be educated. And with Cayenne, we kind of demanded that we want you to gain that knowledge. But that knowledge then comes back and it kicks you in the butt, because some can look at that as, how do you know so much about your IV, the needle size, and about what type of IV, and all of that. So you're so correct in terms of those who are not secure. Doesn't matter how many letters after their name, they're not secure. So they can, I've seen it.
Yes.
Other warriors have said the same thing, that it's a double-edged sword to have knowledge and to also advocate for yourself. And it always doesn't go, it tends to go awry,
Yeah.
which I think
Yeah.
leads to advocacy, that therefore we're not the best advocates always for ourselves, and we have to have other people come in to advocate. Not that they know better, that they know more, just so that you can continue to be seen.
Exactly.
Absolutely, absolutely. Well, you know, I have a problem with warriors being advocates for themselves. My definition of being the best advocate for yourself is to identify your posse. Identify all those people who have what you need in order to get the point across. Because you're fighting at a vulnerable time is not really going to be very helpful to you, because it's going to be stressful. You're going to be in more pain. There's going to be a misunderstanding. You know, you're going to say the wrong thing. The person's going to say the wrong thing. The whole thing is going to go wrong. So advocacy for me, for people with sickle cell disease, is define who advocates best for you. Find your posse, okay? And so when people talk to me about being, I'm going to advocate for myself, I'm like, well, we're going down the tubes real quick, you know, because first of all, that person is not going to listen. They will listen when you have somebody behind you, more likely to listen then, you know. And then the other thing that I think advocacy, a shortcoming of advocacy, is we empower you with all the information, but we don't teach you how to use it, okay? So you walk in, you know, and I shouldn't say this, the guns are loaded, okay? You have all the information to give to that person, but you have to read that person. There are some people who can receive what you give them, and other people you have to figure out how to present it so that they can receive it, you know? And I these kind of things come from because before I came to sickle cell, I was a mental health nurse, okay? So I know that there are a whole lot of folks out there who don't receive things in certain ways, and they're not able to, once this interaction gets going, they're not able to stop, because it's like, you know, somebody's got to be the winner, and it's going to be me, okay? And so I think it's really, really important for us to understand what advocacy really is. It's not, you know, being able to speak for yourself. It's not being able to provide all the information for yourself. It's the ability to get favor as you're presenting that information. And that's what it really is all about, is favor. And so, so as we go forward, not only do we have to teach people how to collect all the information they need to convey, but we also have to teach them how to convey that information in a way that will be accepted and received, you know, and processed. Because young docs, sometimes they done paid a lot of money to go to medical school and to become a doctor. So they know a whole lot, and they do know a whole lot.
Right.
They know a whole lot.
Yes.
It's the way they process what they know, you know, and you have to get favor with them in order for them to receive what you're putting out there, you know, and that's hard sometimes, you know, and you can't do it. Sometimes it takes your mama or your daddy or somebody else, you know, who's there to help you to do that, you know, and I used to tell patients all the time, you start the conversation in a certain way. So, you know, I am so-and-so. I've had sickle cell disease for this amount of time. And though I don't know everything about sickle cell disease, I know a lot. And I want to make sure that you know all that you know and all that I have to offer you, you know. So we're in this game together, you know, and I think it's really hard sometimes.
So I want to share, so recently, there was a warrior who's bi-coastal, California and New York. She called, she was in New York, spoke to the doctor, the attending in the morning, listened well, gave her exactly what she needed. Exactly, no questions asked. Said, okay. And of course I made a little point, but okay. 12 hours later, Dr. Rosenthal, in the night, says, no, she's not getting that. Took her off of everything. That went on for 5 to 7 days. Daytime received everything. Nighttime was taken off. Daytime received everything. Nighttime was taken off.
So there are two different
Even
doctors
the
involved?
nurses said, you have to get her out of here, but she couldn't walk. So we had to wait until she could walk out. So this is real. This is real in the same hospital. So your question is, I didn't hear your question. You asked a question or made a comment?
Oh, he wanted
This
to know
isn't
if it
the
was the
same-
same doctor.
Oh, yeah, if it was the
No.
same doctor, yeah.
I don't even remember, and I probably should have remembered the one who was cooperative.
Right.
So
At least.
It was trauma.
it was. So
We
I'm gonna
remember
just
the
say,
bad
I'm gonna
things
just
like
say
they did.
Smith Rosenthal. Smith Rosenthal. And that's exactly how it went for this young lady.
So it was back and forth. So
And the last time she was in the hospital was 1 year ago. So she's not one that goes in frequently.
Right.
And I shared that with them that she does very well. And so she suffered. It was heartbreaking because we did all that we could. But Rosenthal said no to all of it. And so when we spoke, I don't understand. You're not going to give her anything? Punitively, well, okay, she can have an IM. Yes,
because I need
she
for it
can
to
have an
hurt.
IM. That's punitive.
Yeah.
Not when she's already hooked up IV for the first 12 hours. So yes, this is real. This is why we're talking about, we have to educate. And so we did get favor in the morning, but Dr. Rosenthal, there's words for people like that.
So how long was this person in the hospital for?
5 to 7 days.
Okay. And
Until she
was
could
that her
walk.
normal hospitalization?
No, it wasn't.
So how long does she usually stay in the
3
hospital?
to 5.
So
So what
That-
do you do as a nurse?
So-
that's in
so
there?
that's an
So the nurses, they did advocate. They actually were on our side. They were. I actually spoke to them. They're the ones that said, you have to get her out of here. But she couldn't walk. There was no way for her to get out. She couldn't even sit in the wheelchair. But the nurses, the reason why I know they advocated, because they actually, though they shouldn't have done it, they actually were recording. I don't advise doing that.
Right.
So that
Well, you told her it was
I heard the nurse speaking to Dr. Rosenthal. I heard it. And they made sure that I heard it. They advocated.
They did.
They advocated.
So he was so full of himself.
Yeah, but if there, can we go, what can we do to
So-
make him do what he's supposed to do?
Wait, aren't they supposed to follow what the doctor does?
So when things like that happen, it really makes us have to think about what we can do.
Right, yes.
One of the things, and that's why I was asking Carolyn the question, was that her usual hospitalization stay? You said it was 3 days rather than 7 days. Her insurance company needs to be pulled into that. You don't need to get paid for keeping her extra days, you know? And so there
Well,
are
she was still
things.
in pain
No.
at 7. It's just that That was the opportunity for her to walk
But it
out.
doesn't have anything to do with her. It has to do with the fact that they prolonged her hospitalization because they did not provide the care that was known that worked for her. And so those are the kinds of things that we have to look at. You know, the way that you can effect change is by showing that what that person is doing is not what they should be doing. And so
Well, what
those
would
are
you
the kinds
do? Like,
What- what's
who
the
would-
motivation?
So I would call the
Contacting-
insurance company and report it to the insurance company. I would put it in writing to let them know that this is a person that's usually hospitalized for 3 days if she's treated properly and treated aggressively. She was not treated properly. She was not treated aggressively. It prolonged her hospitalization and therefore it's costing you more money.
Would it be productive to go to quality control? Or
Sure,
would it
you
be
need
advantageous
to
while the patient
you need to
is
go to
there?
hospital administration. You
Right.
need to go through all of those things.
Okay.
That's what advocacy really is all about.
So
is
we did.
making a difference.
And we did. So Dr. Rosenthal is very high up.
Yeah.
So we did. And
Oh,
so
God.
he didn't listen
But-
to, he didn't listen to quality control, the charge nurse. I'm telling you,
So they shouldn't be paid. Should they be paid?
no.
You shouldn't be paid. Hospitals are impacted by not being paid, okay? So if you can collect all the evidence to show that it was their neglect that caused this patient to stay in the
his
hospital
neglect.
longer and cost
His,
them more
Yes.
money,
Good point.
then you can effect change. Yeah,
So the nurses advocate for us when they're not listening.
I'm sorry.
so.
I was bringing up to her point that
Yeah,
the
what
nurses,
can nurses
they're the
do?
first, they're.
Yeah, but
I would-
they can't speak out against their
The doctor.
institution, their doctor. So, but what they can do is chart what the patient is telling them.
Mm.
And then when they go back and they review the chart.
Could that come back on the nurse if someone were to say, oh?
No, she's just charting what the patient is telling her. That's, we can chart whatever patients say to us.
Okay,
We can put it in the chart.
okay. I wondered if that could be a backlash, like, for instance, if the nurse were, given that the nurse is charting the truth, it's not only how you say it, but it's not what you say, but how you say it.
Patient reports,
Okay.
patient
Patient
reports,
okay.
you know.
But if there's any type of retaliation, then the
That's
insurance
what I
company
was
looks
wondering.
into that, the
That's
doctor
the
can
point.
still get in trouble as well.
Yeah, everybody can get in
As
trouble.
long as there's evidence, you
Okay.
can use it against.
Nursing is unionized too.
Okay.
They can report it to their reps as well. So
Yeah.
everybody's in their own pocket of protections, but I still don't understand Rosenthal's motivation for even doing that.
He was just mean.
Like,
That happens all the time in the sickle cell
He was
community.
just mean because I did explain, I said, I'm sure you're aware of NHLBI guidelines.
Yeah.
I said, I'm sure you are aware of ASH guidelines. He said, I'm aware of how long I've been a doctor. That's what he's aware of.
He's
Yeah.
ego, yeah.
Yeah.
But that man shouldn't be a doctor. Like, that's what I'm saying. We gotta also screen
Yes.
people who go to med school.
Well, unfortunately, we can't do that. If you got enough money, you can go to med school. You got that?
Exactly.
Yes, yes. Unfortunately, we can't do that. But what we can do is, and one of the things that I always encourage folks to do is to make sure that they select well where they receive their care, you know. So the doctors that you,
To be honest, no, that's not, I mean, I live here and there's not a great selection. And
There-
we,
Yeah, we're just talking about it.
so everybody thinks you gotta select the doctor that somebody else has. How about you build your doctor? How about you find somebody who's compassionate and tell that person, I would really like you to take care of me. And I'm gonna teach you how to take care of me.
or you have to ask if they want to have a partnership.
You do have to ask that.
Because
But if you say that, they're gonna tell you yes or no.
And that's.
I really
that's
like
what
who-
would
I
to
really
hear.
like
I would
who
to
you
hear a
are.
no and not
I-
string me along.
Yeah, I like who you are, and I would really like for you to take care of me. Are you willing? You know, because we sometimes, what I find in the sickle cell population is oftentimes they just accept whoever they give them. You know, there's no vetting of folks. You know, and it's
Are
important.
you allowed to do that?
Of course, you can interview
That's
your
right.
docs.
Yes.
Of course.
Yeah, I think the relationship between the doctor and the patient is equally as any relationship in our lives.
Yes.
With a husband, with a friend, whatever.
Yes.
So you need to work that relationship because it could start like a friendship. It could start rocky
Yes.
without you liking it,
Yes.
without you liking each other. But I think making that part in progress of building that relationship, as Pat is saying, is like putting that extra effort to even see what your doctor likes. I go to the office, I see always chocolate. So next time come to the office, I bring some chocolate. So those kind of things, like at times, as I said, it might start rocky, but you see how you can, enter into the cracks to build a relationship.
So I'm smiling because I had a previous doctor who I think we got along fine. Then when I made an appointment, the nurse said, "Oh," the way she said, "Oh," and I said, I don't understand." "Well, we're not going to see you anymore." I said, "Why?" She said, "Because we don't make enough money off of you."
What?
Yes. "We don't make enough money off of you." What did she mean by that? She meant I don't come in frequently enough.
My goodness.
So I thought we got along just swimmingly. Next thing I knew, I was dropped because they were not making enough money off of me.
It wasn't a like or dislike thing.
It was not
It
about
was
like
a
or
financial
dislike.
thing.
It was financial.
That's why the money is in the medicine. It's not in the cure. It's not into the curative
Yep.
therapies.
No.
And that just is a
Someone
plain
is asking.
correct what's the word?
Example.
Correlation example of how we have sick care and not health care. Because sick care
If they can
is
ask for a
expensive.
copy of their chart.
Health care is not
Every
expensive
patient
because you
has
eat right,
access to it.
you have the right
Capsule.
doctor behind you,
And
you
you're
have a
healthy.
nutritionist,
And
you're
you don't
healthy.
go in as much.
Then you don't spend any money.
So there's someone
Somebody
on the
was like, yeah.
line. Well, one of the reasons that doctors do oncology as opposed to hematology is that they make more money. Okay?
Yeah.
And so people who went to medical school for all those years, they need to make some money because they got to pay for the medical school they went to. So they're always going to be looking for how they can actually, be ahead of the game. And so that's not unusual for people to be dismissed because they're trying to pick up more oncology patients than they are hematology patients. There's a question on here.
They're asking if the patient can ask for a copy of the chart.
So all patients should have access to their chart. They simply need to talk to their plan and find out how they access those charts. The hospital that they attend can tell them how to access. And any place wherever they are in the world, they can go into their medical record to share that information with whoever needs to have the information. So,
And make sure it's
and
correct.
and the other thing is that they should be reviewing their medical chart
Yes.
because things get put in your medical chart. Sometimes people are overwhelmed and they mischart. Other times people put stuff in there that shouldn't be there, say things about who you are and how you show up that should not be in your chart.
You can also say if we answer a question when they're screening us, it's misunderstood.
It's
Like, just
misunderstood.
example, like, do you drink? Well, maybe once a quarter, like something like that. And then you, so do you consume alcohol? That's a quarter, every once in a
Yes.
while, every once in a blue moon.
Yes.
Well, the person charting that or noting that may just check yes. And then all of a sudden.
And no
you're-
qualifiers.
No qualifier, you're a drinker, and then you're getting messages saying we have an alcohol substance use abuse program for you.
Oh, my God.
What?
Yes.
AI.
Yeah.
I'm an example case. I had to give you my- Yes, and I
Computers
do
don't
maybe once a
differentiate.
quarter. I mean, you know, when I want a glass of wine or mixed drink. But that's, I literally had to go have that corrected.
Because
And they also had me down for, not that, no judgment, but also the
So we
utilization
put
for
heart disease in that
cannabis.
person's chart.
And I
They don't have
don't utilize it. I've tried the hemp stuff or whatever you want topically.
yes,
But when I went to go look at my chart at a place that they love me, I mean, the team at Inglewood, we're like family.
Yeah.
But the LVN or the nurse that took me in, that was my intake person, totally erroneously noted and misunderstood my yes in my qualifier. And there were other boxes they could have checked.
yeah.
But they checked the one that before I knew it, I was getting all these substance use abuse classes to take. And in my
She thought you meant once every quarter, every day. Like, that's what she
yeah,
thought.
but every quarter, right, every quarter.
Every quarter,
Too much
every day.
information is
Right.
also a bad thing.
And so that too, that's why Renee, your question's so well done.
It's
And when you
it's
said,
so
we
important
have
for
to
you to
audit our own
review
records.
your records.
yeah, and
There are
demand,
things
demand
that-
corrections when necessary.
You know, when you're charting is a little better now because it's on the computer. But when I was charting, we were writing what.
Manual.
Yes, it was manual. And so it was easy to put the wrong information in a chart, you know, and as easy as it is to put it in, it's harder to get it back out.
Yeah.
Okay.
Yeah.
So yes, I tell patients that all the time. Patients come, they don't even have access to their medical record. I'm like, get access to your medical record. You know, they stay in LA all the time, maybe, but there might be a time when you travel and you need access to your medical record. You're not going to take that big old chart that's this big with you, you know. So yeah, it's important to have access to it.
One thing with that Adina's done a good job of is she tells patients when you are answering those questions, be deliberate in what you say and be very specific. So
Absolutely.
don't just say, yeah, do you drink alcohol? Yes. And
Because some
do a
people say
qualifier?
yes.
yeah.
It's yes to everything.
She said start with the qualifier and then see if they'll ask you like more of a clear.
Or say, what are you
Like-
asking me?
Or
you
like,
know.
or do you drink alcohol once in a while? And then
Yeah.
you get rid
Yeah,
of the
the
whole yes or no
qualifier.
kind. Yeah.
Yeah,
You get the
so
qualifier right
yeah,
off.
and sometimes just repeating the question they've asked you.
Yeah,
you
that's
know,
a good
so
one.
that
It's
you-
like
So that
Every
you
way-
process and you make sure you're getting the information.
Yeah.
Yeah,
Sometimes when you check in, you don't have that interaction. It's just a.
it's a
Yeah.
check off.
That's it.
It's a check off.
Thank you, Renee. for
And
that.
they need to
It
put
is
a
a
box
check-off.
so you can add to
Notes.
the check.
Yeah.
you know.
Yes,
Can I-
but you need to be aware that it goes down like
And they
that.
won't let
So
you continue
yes.
on with the paperwork unless you answer all the questions. But
Yeah.
the questions, you need to have a specific box
Yes.
because it doesn't fit you what's in the
Yeah.
box.
And given that you would say quarterly and you qualified it first, they can still check yes. So
yeah,
given that, before you leave that station where they're taking your blood pressure and your temperature, ask that person, what did you put down for me? Close the loop, like when we give someone a
Yeah.
phone number or an address, to make sure that our listener received our communication.
Yeah.
Because between a speaker and a listener, there's this space that's called noise.
yes.
And if
And
noise
it's a
comes
lot of
in,
noise.
twist, it's a lot of noise, interpretations, whatever, languages, all the different barriers.
Yeah.
So what we can, and I'm talking to myself now,
Yeah,
what I needed to have done and what I will do in the future is not only when I answer, before I leave that station, because you know they want to get to the next station, say, read back to me what you wrote down for me or print it out, whatever. But read back to me how you clicked and ticked those boxes based on my verbal input to you. Because I know I was very clear about quarterly. I mean, I understood that. I was shocked to see what I saw.
Yeah.
You understand? So in addition to speaking, ask the person who listened to you, how did you interpret me? How did you put it down? And if necessary, give me a copy of my EMR is so very important now that we have electronic medical records. I'm just going to say this out loud. I know that in all the beautiful things that we've done, I think we need to add a session on how to teach patients how to get access because I have a lot of
Yes.
warriors that call me, they don't know how to get access to their EMR, their electronic medical records. They don't know how to navigate those platforms. They don't even realize that my chart and all the other ones exist. So I think we need to educate our population on the how to get to their medical records and how
Well, we
to
need
get
to
them. You don't have to ask
We need to
anyone's
tell them,
permission.
give them
New
the
topic.
fact that there are medical records.
Right, get one, get it.
Number one.
Yeah. There's a.
It depends
there's
upon what
several there.
system.
Yeah.
It depends upon what system your
Yeah, sure.
hospital
That's all,
utilizes.
yeah.
There are different
They
systems.
do have differences, but there's a, the
But-
knowledge that they exist.
But we don't even have to teach them that. The hospital will teach them that. They just have to request
Right.
access to their medical records. You
We
know,
have to
and
teach them the importance.
But yeah. and-
we need to teach them the importance of having access.
and-
But their hospital is actually the one that knows what platform they're using.
Sure.
And they are the ones that will do the education in terms of how do you access, how do you make your password, how do you do the things that you do
But they have
in
to know
order to be able
ask
to go
for it,
in. But they have to know
to ask.
to ask.
Because like Epic has one platform
And-
and others have
And,
others.
and the first part of advocating for yourself is having access to your information.
Absolutely,
You have got to have access to your information,
absolutely.
because once you review your chart, you're going to be, almost every chart probably has a mistake in it.
Yeah,
You know,
yeah.
you're going to be amazed at what mistake is in there.
Like even the date.
Yes, yes.
Can I share on a positive also what's wonderful about having access to our charts? Let's say we have lab work that's done, right? If it's, we can see where we're within the normal bounds and where we're outside of those.
Absolutely.
And most medical records, like Epic, for instance, they also provide, you can click on that particular thing. Let's say that your reticulocytes are high or low, whatever it may be. You can click on that word and it will give a tutorial to tell you this is what this means.
Yes.
So having access is so positive because I've gotten to know myself better just perusing and studying my medical record and reading a little bit deeper as to what this MCV means and what does that mean? Because otherwise, right, the nurse.
Patients always say, what is this?
So how many,
You can click
so
on
how
that
many of
word
you
and-
guys in here have access to your medical record?
I do. I look all the time.
Okay,
So,
so we all have to have access to our medical record because we never know what's going to happen, you know. And really, I know medical records are really big, you know, but I feel like I want to print mine, you know, because I never know when I go on there and I'm not going to be able to get it. And then the other thing is things are entered in your medical record that may not be reality. Somebody might have been charting on you, charting in your chart, that they were charting on the patient in the same room as you are. You know, so you do have to review and when you find things that don't belong there, or they may have quoted you as saying something that you really didn't say, you know, and
can I also say?
yes.
You also, in reviewing your medical records, you may also be able to ascertain how the medical team or doctor has put notes in there. For instance, when I was pregnant with my daughter, and I would go in with the NIH book that you gave me way back in the 1980s, and I would go in and, you know, I'd have my little book, and I would say, you know, this is what I know what's going on with me. And I had two different doctors. I had a perinatologist and an OBGYN. And my OBGYN, who happened to be a brother, there was a Black African-American man who advocated, he says, Sheila, do you realize that the way they've got your charts noted that you intimidate the doctor? I said, what you say? He was letting me know, when you go in, we were talking about our audience, he was basically saying that when you go in, being knowledgeable, speaking as you had noted, that those doctors kind of put some kind of code, some kind of way that they say this particular patient, and if you see that, you can know how you're being perceived. So for instance, knowing that, I had to think about how to adjust my approach. what you said, Pat. I had to realize that because I came in perhaps with attention knowledge, I'm no doctor. I had the books, I read, I researched, but how they were receiving me to them, it was threatening. So when Mary said, for instance, we have a lemon tree or whatever, I knew that, hey, when I go in there, not only with my doctor, but with the nurse and with this social worker, I brought them all lemons. And I said, thank you for your care, because I had to realize I had to diffuse the fact that they were seeing me, because I wasn't there to threaten anyone. I was just there to give good care. And guess what? You're not a sickle cell specialist. I'm helping you help me. I'm trying to keep my baby.
And the person coming behind you.
So why do you think they were intimidated by you?
My articulation, my knowledge, my boldness.
Because you knew more than them.
And my book.
It wasn't because you knew more than them.
No, but that's good, okay?
In sickle cell. But
You're taking notes.
Yeah, and I do. I take notes and I'm just engaged, right? And I'm not afraid.
But
They don't intimidate me.
But I think sometimes it's important to notice those things because then you level down or level up. Because we have the capacity to do it. And kind of setting that level is like, I know more and I know that, but I'm just gonna level down a bit so you don't feel threatened by what I'm saying or how I'm saying it. And that's kind of, it comes more like, then that kind of strengthens the relationship. And then you know whenever you need to come maybe a bit stronger. But and then as well kind of level down too.
I'm not kind of person that says we're not working well together, okay? So what can we do about this? Okay?
Yeah.
But that can also be a double-edged sword.
It can.
It can.
It can because you can only level down so much.
Yes, exactly. But knowing
I kind of would, I mean, just to go off that idea, it's not necessarily leveling down. It's more about approaching it at a way that maybe they can understand.
Yes.
So you talk their language instead of your own.
Yes.
And I know this word is bad to use, whatever, but you're more manipulating them in the situation into both parties actually having something.
You're using psychology.
Yeah, and I think that's why I always go around preaching the word manipulation in a more positive way, because it's the only way to actually get people outside of themselves. Because if you let people just think for themselves all the time, it's gonna end up.
I like to open the door so the elephant can come out the closet.
Exactly.
That's what I like to do.
Based on our personality, we have different approaches. For instance, for me, because you guys I've shared with you, and you can see with me, I'm very relational. And so in considering my audience, I'll look at that individual, that doctor and whomever, and I'll think, what's their gender? We could be dealing with some gender issues. What's their race? What is their culture, background? What's their age? Right? Like Dr. Rosenthal was like, I've been a doctor 999 years. Okay.
And then it's time for you to retire.
Right. So always considering in all communications, first of all, considering your audience. And so with those considerations, as Mary's saying, it's not so much as leveling down, but what it is utilizing intelligent communication tools so that you recognize your audience, you're looking at them and you're reading them. And you know that this is a chess game, baby.
Right.
So I'm not here playing checkers, but it's a chess game. So I'm gonna think about all those factors as it relates to that person. Then this is what I do, particularly when I don't get good care. If I'm in urgent care or emergency, after a while you go back and forth and they can't find the veins and all the other stuff and the meds aren't coming. I literally will just look at them and say, if this was your mom, depending on age, because I'm 67 and some of these doctors are in their 20s, I'm like 30s. I'm like, if this was your mom, I can be
Is this what you'd want for her?
Is this what you would do to your mom? Is this your wife? Sometimes I'm desperate, we're about losing our mind.
But it's just like,
I literally
like them.
I don't have to like them, but I literally, it's a form of using my intellect and connecting with their humanity and allowing them to get outside of their godlike mindset of being a doctor and saying, if this was your child, your wife, your mother, your sister, your brother, your uncle, your daddy, would you treat them how you're treating me right now? You see how I'm feeling. I just want you to think about that. And I'm telling you, that technique has literally helped me.
Yes.
The sad part is, though, the Rosenthals of the world don't even bow to that.
Well,
So-
but everybody's not a Roosevelt. You
But-
can always.
but
reach-
But that's why it
what-
says the Rosenthals.
But that's when you have the
That's-
right to dismiss that doctor
There you
and
go.
ask for
Ask
another
for
And
doctor.
let me tell you what I've done, because I was denied being sent to a perinatologist. I literally left the doctor's office, went to the quality control, I always forget their name, the place where you complaints, whatever you
Yes.
call it. I let the nurse know before I was going there, because I know she would tell the doctor. I said, he's not doing me right. He's not doing me right. I'm gonna go in and make a complaint, right? So you let them know. So the nurse ran and told the doctor, before I can put it in writing, the Roosevelts of the world, the best thing you can do is to document it and carbon copy as many
Yes.
departments and everything else, because now you're outing that person.
Yeah.
And we don't know who else.
And that's
may
not the
have-
first complaint they've
That's-
gotten about that.
You just
person.
took it out. We don't know who else
Yeah.
may have.
Right,
And
right.
we're representing probably 20 to 30 patients, because everyone else doesn't write, they don't
Right.
fight.
Right.
They don't,
Yeah.
they don't have
They
whatever it
just let it
takes.
go.
They let
Yes,
it go.
go, exactly.
So I agree with you, but that's not the end. A written word goes and positive. I think it's just as important to write beautiful letters of commendation
Yes.
like we had yesterday.
Absolutely.
And to people who do you well, because see, both of
Yes.
those records are on file
Yeah.
from you as a patient. Both of those are there. So
Yeah.
if you balance out like, well, she ain't always complaining. She done wrote this beautiful letter about Nurse
Yes,
Pat and
It's
Dr.
actually a very
Rollins.
good point. I don't
Yes.
think enough
Yes.
patients.
Commendation letters.
yes.
Okay, I'm talking too much. I get a little bit turned up.
So I can remember I had surgery once, and the doctor I had, doctor, I really liked her a lot. She had come on the case just to take care of me. And at the time, I had been invited to speak at a conference in Brazil, and I had to have a surgery done. And she said, "You can't go." And I said, "I'm gonna go." She said, "But you can't travel after you have the surgery. And your surgery, you just had the surgery." I said, "But I'm going." And she said, and my kids were in the room too. And she said, "But you could bleed after the surgery trying to move your suitcases around and stuff." I said, "I'll pay somebody to move my suitcases. I'm going on this trip." And she just started laughing, She said, "Your mom is determined. She's going on this trip,
And you survived.
And I
You're here.
survived. I survived. But I left with her well wishes,
Yes.
because she said, "As long as you promise me,
That you're
you
not
will
gonna-
not pick up the suitcases."
That's right. You worked out a deal.
Yes, we worked out a deal. And that's what individuals have to learn to do. You have to learn when to dump them too, okay? When you recognize that this is going no place quick, and it's not going to ever go anyplace, then you need to start Rosenthal.
Rosenthal.
That's when you start
Nobody
searching
will
for that
forget.
person that works for you. Carolyn can tell you an experience. that She has an amazing doc now. You actually met her doc, because you went to see her doc. But she went through struggle before she got to that doc, and I was mean to her during that struggle.
You were mean to her?
I was mean to her because she's my little sister. I can be mean to her. Okay.
Yeah.
And so I would ask her every time I saw her, "Did you make your appointment?" And she would say no. And I'd say, "So how is your care going?" And she would say things weren't going well. And so one day she came and I asked her the question, and she told me the same thing. And I said, "You like to be treated bad." I hand selected a doctor for you who you're going to love.
Right.
But you won't go to see that doctor because you like to get treated bad. So what did you do, Carolyn?
She finally made the appointment.
No.
So the missing piece was that
Her
I
insurance didn't
had
allow
an
her.
HMO.
Yes,
And in
yes.
order to see.
But she didn't tell me
the
that at the
doctor,
time.
I needed to switch to PPO. PPO costs more money, and I finally had to make the decision.
Are you worth it?
I need to. I will figure out the way to pay.
Yeah.
I will figure out the way.
But we didn't have that other part to the conversation. I just couldn't understand why.
Right.
Yeah.
And that was the why.
Yeah, and that was her why.
That's
That
why you
was her why.
misunderstood her as wanting to be treated badly.
No, I just
she was
said
being-
that.
no, that was just-
To move the needle,
You
okay?
know what Dr. Raleigh is sharing is a condition that many warriors have.
Yes.
Is that because of economics and insurance, there's a, yes, there you go.
Yeah.
We don't have we may not have the resources to get the premium care, and that is a huge.
But you guys are not alone.
We're not.
Every other population has that same.
I was just gonna say,
Yeah.
in healthcare in general, like.
It's the US
Yes.
system,
Yes.
healthcare system.
An off-topic subject, my mother had a heart attack 7 years ago. And the hospital that she always went to, quote unquote, her cardiac doctor was supposed to be really good for her, decided to put 7 stents in her when she actually, years later, we found out he didn't even need to do that. But because he was experienced, he knew what he was doing, et cetera, et cetera. My mom had been a patient of his for a long time. He decided to go ahead with that procedure, and it actually created side effects and backlashing effects to her.
Yes.
To where she had to remove herself from his care, and I almost got into an altercation with him myself, which is why me and doctors don't get along 100%, even though I wanted to be one. So it took us 7 different doctors, 3 different hospitals to find the person who I am so. If anybody even talks bad about Dr. Fuhimori, Sakamoto, I will literally rip them to shreds because this doctor is a saint. He gets it. He understands. He's everything I wanted to be when I was trying to go to med school. Listens, educated, understands. Like we come up with different ideas, and he listens to it. And actually, and he like goes with it. Comes back with us every visit about stuff that we talked about that he researched on his own. But it took us literally almost a year and a half.
But he loves you guys.
Yeah, and we love him.
Yes.
Yeah, and he even I won't say anymore because I don't want anything to get recorded because he told us some stuff that probably
Yeah, don't say.
Yeah. But that's how I know that relationship was built. But the sad part is that it took us a year and a half to get there. And that whole year and a half, me and my brothers were like, is my mom gonna survive this?
Right.
Which is how many Americans go through that? It's ridiculous. This is supposed to be the land of opportunity, the land of rich people. Doesn't seem like it at all. So
No. America does not take care of her citizens.
no.
Well, this was a very robust conversation. And apologies that Dr. Caroline, I know that it was her intention to be here. She had one of those weeks, as I'm sure many of us have had it at some time or another, so she wasn't able to make it. But next up, we have warrior experiences. So this is where, Renee, you're going to share. And we're going to do it a little bit different. So normally we have it where you share what a good experience is, what a bad experience is. But what I want to do is engage everyone. So starting from Tony, going all the way around here, that they're going to ask you a question because I want them to know you as a warrior and to ask questions that will then build upon your warrior experience. So not you just, telling the story, but for you all to be thoughtful about the questions. And you can ask anything, and I'm saying this on her behalf.
Yes.
You don't have to answer anything.
You can ask anything, but we're doing it differently.
Just move a bit towards.
But you can ask anything as we build and understand and get to know Renee. We're also, Ashley couldn't make it. So I think between Sheila and I, after Renee, then Sheila and I will be able to kind of talk about war experiences as well. But right now, first up is Renee. And so I want you to get to know Renee. So she's not going to share any information. So if you want to know more about family, her experiences, complications, you're going to have to ask those questions as you get to build what these experiences are for her. Okay?
I have a question.
Well, then what we're going to do is question about the
No.
activity?
No.
You want to start first? Okay. So you're going to start first.
Yes.
That's fine. And so that means everyone needs to at least ask a question and then go around. Doesn't have to be in order, that legalistic, but I want everyone to ask a question. So Donna, I'm going to get back to my seat and then go ahead and feel free.
Renee, I just have to ask you, how do you do it? You're a warrior, you take care of your mother, you have your son, your husband, your crisis. I so admire you for what you
I
do.
like management. I chart, I use colors. Every member of my family has a color associated with their calendar. So I can look in 2 seconds, I say, oh, I have 4 reds and 2 greens. I need to be in this area, I need to be in that area. So I like to be very organized. And I'm almost anal about that, which drives my husband crazy. He's the opposite of
Opposite attract.
organized, yes. He likes a little chaos.
Well, you make a good couple then.
Yes, it makes it interesting. So I like to be very well organized. In the event that we know sickle cell arises, for me, it's always 2 a.m., between 2 and 5, and those are not doctor's hours, right? So you have to prepare in advance, making sure you have some soup in the fridge, making sure you have a ride or several rides, several transportation options for your, little ones or even your big ones, because I take care of my mom as well. And like Pat says, you have to know, you build a community. I don't have family here, but I have built a family here. And that has made a huge difference. When I didn't know anyone, it was very chaotic for us because I always had to call my family from Northern California to come, 4 or 5 hours. And not only is that costly, you can't always take off work. So that in a nutshell, being organized. I love being organized. I like to have 2 or 3 plans. If one doesn't work, I like to be able to deviate and do something, pivot, I should say. So that's what I like to do. I like to be very well organized. And I like to be on time.
Of course you do. Okay, so how long have you, I don't know, how long have you had sickle cell? Are you're born with it? Right, because I still they find it when they, okay, so I don't know a thing.
No, that's a great question because a lot of us, especially in the medical field, you'll arrive at the hospital or a clinic and they'll say, oh, so how long have you experienced sickle cell? And I was like, well, since 1975. But I wasn't diagnosed until I was 12. But that's a great question. And I say, as a warrior, we're highly offended. But it's I don't know how to explain it, but we're like almost incensed. We're like, what do you mean? I mean, you have, no, I'm just letting you know from it. When someone asks us that, we're like, but you're in the medical field. You should know that. I mean, we learned that
Oncology.
we learned that in 7th grade or 8th grade, just basic, what did the Punnett square. So I'm glad you brought that up. That just really enrages us because I've had that encounter in the emergency room, in urgent care. And they say it so almost nonchalantly.
It's innocence.
Yes.
It's innocence.
And I said, you are dealing with my life, ma'am or sir. This is not,
So
that is, yes. So I'm glad that it is a hereditary disease. Let's put that to rest.
as you're talking about that, I want to tell you that if you talk to nurses and doctors all over the world, they don't know about sickle cell. Because in nursing school, there was one paragraph about sickle cell disease.
Yeah,
Sickle cell disease was not
system
important.
is
It
wrong.
was not important because it primarily affected African Americans. And so that's not the disease they chose. They chose cancer. They chose all these other diseases. They chose things that there was a disease where people, I can't even think of the name of it, where they actually almost look like these really weird looking people because everything is overgrown and stuff on them. You know what I'm talking about? Elephantitis type condition. We knew about that, but we didn't know nothing about sickle cell. And I'm telling you, I told you I researched to find a disease that looked like me. And that's how I got into sickle cell. I knew nothing about sickle cell.
Well, I'm gonna always just add references and facts. So it's not a question. So yes, according to ASH, they did a survey. 80% of doctors said they do not have the knowledge and they do not know how to treat persons living with sickle cell disease. That's 80% across the country. So the question is relevant, and the fact that people do not have knowledge is real. 80%.
Yeah. So
Anyone
I
else have a
attended
question?
high school where a bunch of my patients, when I became the sickle cell nurse, became my patients. I went to school with them, all through school. Never once was there any conversation about sickle cell disease. There was a family with 6 children with sickle cell disease who lived up the street from me and around the corner. I did not know they had sickle cell disease. The patients that I serviced, I thought I knew them in high school, and they didn't always go to high school. I just felt like their family didn't care whether they went to school or not. So the reality of the lack of knowledge about sickle cell disease is real. It was not until I landed in the sickle cell job that I realized the latitude of sickle cell disease.
And you also have to remember or realize some patients, or some people that I'm not patients, I'm a person living with sickle cell disease. They don't always they're not forthcoming.
True. They don't share it.
No, I didn't
don't.
disclose my
Less than.
disease
I'm less than. I'm not a whole person.
for years,
How
even though I
many
had a
years?
proper
Yes.
diagnosis.
How many years?
Oh,
I mean, you're talking
probably
30
10 years.
Oh, okay.
Yeah, you stumble into those conversations sometimes. But only reason I knew people with sickle cell is that I landed in that area. I never would have known those folks had sickle cell.
Kimball?
Yeah, that was my question, Renee. What's the motivation behind choosing to smile and be your infectious, high energy self versus showing the world like what's really going on the inside? Because I think it's awesome that you're able to do that. But what's the motivation behind it?
Well, even before I was properly diagnosed, I was symptomatic, but I didn't know I had sickle cell disease. I love children, and I think part of my energy, I teach them how to read phonics, and you have to be energized and kind of like engage them. And so I have to remember, I've done it for so long that that's just a part of me, even though I probably should transition into more of an adult. But I love the foundation before they're even who know who they are to help them in some way, like communicate with the world. And I just remember learning from you was awesome. My mom's a nurse by trade. My dad and stepdad both work with their hands. One was a correctional officer, but they had this. They wanted life. They wanted to understand life. So tinkering around and just having that education and just always being busy with something around them to educate themselves and build things. And so I think I just kind of gotten to that point where I'm excited about education. I'm excited about learning. I'm excited about you learning. And I want to make it fun for you. It's my son.
But I think it's cultural. We're taught from the times that we're young children. Suck it up, okay? If you spend all your time complaining about stuff, and talking about stuff, you ain't gonna get nothing done.
And you don't want to bring that energy into a room, even though you don't feel well.
Right.
You still want everyone else to experience something that's not
until we have to take you out on the street.
Tony?
Having crises, you're gonna have. How do you prepare and manage for crises that it's coming?
I think that goes back to Pat, your village. You have to prepare them because I'm the only person, most people in my friend village about sickle cell, they know nothing about sickle cell except for what I tell them and how they, I invite them to conferences, that we're in, we break bread, so they know me intimately, but they've never met a person living with sickle cell. So we have to I continually give, as I get information, I give them information, because I never stop learning. And that's the main point the main thing I always ask my friends, don't be afraid to ask me questions, because I remember for a long time, it was like embarrassment and shame associated with sickle cell. And that was another reason we didn't tell, or I didn't tell personally, because you're lazy, you're shiftless, you're drug addict, you're everything that's negative, but they never see us being doctors and lawyers and moms and authors. And we want everything that everyone else wants. We want to be loved, we want to love, we want to enjoy life, we want to go to Paris, we want to do everything that everybody else living with another chronic illness or not a chronic illness, just basic human, like our humanity. We want you to see our humanity.
Yes.
And unfortunately, sometimes that means you have to, your crisis is at a 10, but you can't show up at a 10. You have to show up at a 5. And that's a double-edged sword too, because if you say you show up at a 5 and they're like, but you're sweaty, your RBCs are off the chart, your white blood cells, how can you be at a 5? And I said, well, I had to test my audience. I don't know how you're going to receive me, so I have to come in low and then build up. And that, to me, I think is shameful that you have to.
That's kind of a problem too, because if you build up and require more medicine, then you just want more medicine.
And
that's why you're
delaying your
numbers, because you want more medicine.
So that's how I prepare. I put my friends on alert, my family on alert. I call my hematologist, and I said, I for 3 or 4 days. We have to change up this plan. I can't keep going back to the ER. Can't go back to the urgent care where they know 0.
Yeah.
So that's how I prepare, making sure I have a plan in place, or plans in place, because nothing's perfect, and you always have to tweak.
So you were diagnosed at 13.
Yeah, I was
12.
But at adolescence, I was going from 6th grade into 7th grade.
So in most families, the diagnosis is made very early.
Earlier than that?
Mm-hmm.
Yes.
Yeah, and birth.
Newborn screening. So their babies are diagnosed shortly after birth, which changes the whole trajectory of life. So you actually were leading what, quote unquote, a normal life until age 13.
No, I was symptomatic.
But everybody was treating you like you were a normal person.
Correct.
How did that change once that diagnosis was made, number 1?
Yes.
And number 2, what effect did it have on your family?
Ooh. Do we have 5 hours to unpack that? The cliff notes.
I'm sorry, but
it was a relief, but it was also a devastation, because when the doctor gave us that diagnosis, we thought, oh, finally we have something, we understand what it is. Because the doctors told my mom that I was had a seeking attention behavior. Like I was just coming in to complain, and I had growing pains, and I had severe pains in my legs, severe pains in my legs, and they just didn't know what to do with me. I had ridiculous nosebleeds. So when we finally got the diagnosis, we're like, oh, and they were like, what's that? Because the doctor said, I think you have leukemia. We're going to do some more testing, and when we come back, we'll let you know. And then when they said sickle cell, I was like, is that better than leukemia? Because I'll take it. And then we figured out what sickle cell was. I was like, nah, I don't want that. I'll take the leukemia.
They want it better.
Because you know that at some point, leukemia, if you don't pass away from it, you get a cure. Yeah. Sickle cell, back in the 80s and 90s, there was no cure. You had hydroxyurea, and you had pain meds, and you had hydration. I mean, it was very few things. And a lot of pain that you had to dumb down sometimes because you didn't want to be known as a drug seeker. And that's the most painful experience from being diagnosed to now that I still wrestle with mentally,
Yeah.
is making sure that I convey that I am in pain, but I also, it's a thing with me too, that I've been on almost the same pain regimen since I was diagnosed, and I'm getting older and I'm aging, and things are starting to happen. So I have to tell myself, and I haven't really, the reality of, I have to start doing things differently, but I don't want to do things differently because in my mind, I'm stable. I don't want to rock the boat, but my body's saying, no, ma'am, you're not stable. And the boat is rocking, so you should pay attention. So that to me, I'm just kind of coming to grips, I'm peripausal, I love hot and cold, I'm hot and cold, and it everything is sickle cell affects every part of your body, and then life is lifing, right? Life is coming, you're aging, and then we don't know, is that just a regular trigger, or is that something related to sickle cell? So you're always investigating. It's like you're a 24-hour investigator.
So
Yes.
So back to the question. So many of the folks who have sickle cell disease, once families receive diagnosis, it changes the whole
The
family.
dynamic. It does.
The folks that were close move further away because you have this person who's sick, and so they can't participate in all the things that everybody else was participating in. Did that happen in your family too?
No. Just thinking about COVID, before I even go back to the 70s, 80s, 90s, I had to tell my son that he couldn't participate in certain activities because he could bring something home to me. And to that point, I don't think I really educated him enough, because even in my own family, I hide my condition because I don't want to be known as the sick one. So I, just address it and move on. And I think that was a disservice to my son, because now he sees more of the physical manifestations of the disease, and he doesn't know how to digest it. He's known all my life all his life that I've had sickle cell, but I never let him come to the hospital. In my mind, I'm thinking I'm giving him a normal childhood. I don't want him to grow up in the hospital, and that's no judgment on my other warriors that bring their children to the hospital. I don't think I have OCD, but I have some tendencies. And I'm like, oh, I don't want him here, because babies, they crawl and touch and put everything in their mouths, and I'm grossed out by that. I don't even want to be here. So I kind of just shielded him. And when I got the diagnosis, my mom, training as a nurse, she bubble wrapped me. She's like, you don't go anywhere. You don't see anybody. I mean, I was like a newborn. Nope. You have to there's all the protocols you put in to come see me. Like I was on display, like I was a crystal flower or something.
Yes.
So did your siblings feel different about you afterwards?
I don't think I noticed till later in life, because when I first diagnosed, that was the year I almost died. We had so many complications and I spent the majority of my summer in the hospital that year. And still, growing up in Northern California, I love Kaiser. I love my hematologist, and I love my pediatrician. They didn't know about sickle cell. They had to call down to Los Angeles and get advice for them to treat their patient up in Northern California. I never till I left Sacramento County, I didn't meet another person living with sickle cell, and I'm sure they existed. But that was another thing that was why we hide, because what happens when you recognize somebody that looks like you come out of your shell, right? You're like, oh, that person has the same interest as me. I'm gonna go over there because we both like British novels. But when you don't have any kind of similarities and you're reading a room, and it can be very intimidating, and we already know that it can be harmful, if not deadly, if you encounter the wrong medical professional, then you start kind of going inward, and you're like the turtle. You kind of put your head out and see, is this a safe area for me? Before the term safe area and safe spaces, we knew that internally that we needed those safe spaces early on, because we already were receiving that judgment. So even though I don't think I knew the word advocate, but I knew already that I had a job to do. And it was a big job for a 12, 13, 14-year-old. Had an amazing science teacher, and once she found out, I mean, whoa. I think she was more interested about my sickle cell than I was. I was trying to downplay it. And she was like, so what are we, teaching the whole class. And it was, and I'm still trying to keep it on the low. She's putting me on full blast. And I'm like a science experiment, but in a good way. She was saying, this is, if you see Renee, if you see jaundice, if you see this, you see that, you come report to me. Whereas, I had a PE teacher, she's like, I don't cramps, no cramps, sickle cell, no sickle cell, we could get there, that's right. So I had, different experiences, just even in my space, you spend, that's your job, right, for 12 years at school.
Yeah.
So how do the teachers treat you? How does the administration teach you? I didn't know anything about an IEP. I didn't know anything about any of that. I look back on that and I said, wow, I could have had a different experience in school had I known that I had the right and the privilege to have a personal plan, because I missed a lot of school. I mean, I still retained my A average, but it was hard. I mean, you're sitting here, getting a transfusion and you're trying to, I call it the Jesus, when you have both, you have infusion and you got IV. So you can't really turn. Right. You're kind of just laying like this in the hospital and you're trying to do your homework. Because I'm a person, like, once I dedicate myself to something, I'm, excuse the language, balls to the wall. I was like, metal. I go all the way or I don't do it.
Type it all the way.
Yes, very type A. And I don't like to limit myself because of the sickle cell. I learned from Pat a long time ago how I can maneuver, how I can come up, I can go over, I can come through. But I never, and even my mom, I think at first she limited me because she didn't even know, as a healthcare professional, about sickle cell. But once she figured out it was safe to, take some of the bubble wrap off, then she was like, go. I track, volleyball, soccer. I didn't know too much about soccer. I enjoy watching my husband and son do it, but it was unlimited. I was unlimited. I was limitless what I could do. But I think still in the back of her mind, she was like, that's my baby. I want to protect her.
Yes.
Any kind of injury. She's like, see, now I let you do that. Look what happened. So now we're not going to do that anymore. So it was kind of a give and take, with, push and pull with her to, mommy, please let me do this. Mom, let me, I want to have a life that's normal. And I don't want anybody to see me as a person living with sickle cell. I want to see sickle cell when they see me. Right. And that's another reason why I don't express right away that I have sickle cell. Right. Because I want them to see the whole me first.
Yes.
And then I can explain, I lost it, but I have a Medi brace. I said, forever, a good friend of mine at the time, she said, I don't know anything about sickle cell. If something happens to you, I am going to be scared.
Yeah.
She, out of her own money, brought me a Medi bracelet and said, what do you want it to say? And I, type it, sickle cell, I have my allergies. I mean, I think I need like 3 or 4 of them, but the allergies going up my leg now, or wrist. But at the beginning, it was just a couple of allergies. Now it's expanded, but just the knowledge that she said, I don't know anything about sickle cell, but I don't want you to die. I don't want you to, I want to be able to help you if something happens. I was 40 something. Of all my friends, not one person ever said, what do we do in a crisis? And it never even dawned on me to educate my own friends what to do if I have a sudden episode.
Right.
And that she opened my eyes. Brand new relationship. She said, I do not want to have anything happen on my watch. You better tell me what to do.
So you said your type of sickle cell. So what type of sickle cell?
I'm hemoglobin SC.
Okay.
So she has
that means nothing.
She has sickle, and she has another abnormal hemoglobin C type. C does not sickle; it crystallizes, so it increases viscosity. So her circulation, is impacted by her sickle cell disease as well. But she has 2 abnormal hemoglobins. Everybody has, most people have AA hemoglobin, which is 2 normal hemoglobins. She has 1 sickle and 1 C, which is
both of hers are bad.
They're both abnormal, yes, but 1 sickle,
They're not bad.
the
They're
other
different.
crystal.
Yeah, they're different. Well, but they're not.
I'm joking.
I know. They're not good for you.
She doesn't have A.
Okay.
Okay. Renee, you're a great speaker, by the way. I just want to say you really present so very well. Thank you. I have kind of a question that's two-sided, kind of a yin and a yang, a dark and a light side. So I'm gonna ask the dark first, but allow me to go to the light. Have you ever experienced in your family where you may be in an active crisis and people just ignore you and kind of overlook it, be it either they're denying it or they're dismissing it, or they say, well, you always have these.
No, because I hide it very well. So the only time that they see me in that much pain means I'm off the charts. I can't hide it.
Correct.
I was in Texas on vacation. And I was with my cousins who I hadn't seen in forever. I mean, I have 60-something first cousins.
Yes, wow.
And it was so exciting to go down, the humidity. Oh, Lord have mercy. Just my body acclimating to Texas was
a trigger,
not a fun time.
Yeah.
And then going to a family, family reunion meeting. But long story short, I'll fast forward. I was having a episode, and these are my new cousins. Even though we're related, they're new to me.
New to you.
And they are just like, oh, she can, she'll just lay down. And I was laying down in a hot car. Like, that's a no-no. But it came on so strong and so quick, I couldn't even advocate for myself to tell my cousins, hey, this is not like me just being tired or me being sick because I'm in Texas weather. Because he knew when I got off when I visited, he said, oh, California's presenting because you're not used to this heat. I said, I'm not used to this humidity.
Right.
And so that was since then he's gotten better. They've gotten better. But
sure.
Even my aunts and my cousins. And then the first thing I was like, I don't want to ruin their vacation. I don't want to ruin their time. So I'm just trying to be quiet. But at some point I was like, I'm going to need to go to the hospital because I'm going to die in this car if I stay here too much longer. Right. And that to me was scary, that I had to tell them how serious it was without trying to scare them.
Exactly.
Did you tell them you had sickle cell, or they still at that point didn't know?
They knew, but they didn't know any.
They don't know what it was.
That's
what I find in the family is that for me, I was wondering if for you, not having sickle cell anemia. So you asked a very good question. Sometimes those of us who do not have SS, we're treated a little bit like redheaded stepchildren.
Oh,
like you ain't really got
you're the milkman's baby.
There's a term. You ain't got full-blown sickle cell.
Which is ridiculous.
So with that, sometimes there's dismissal of our complications and our conditions living with a genotype of sickle cell. Sometimes there's denial. And I'm gonna be honest with you, sometimes there's just an ignoring. There's we don't wanna think you that bad kind of thing.
Oh, my own doctors.
Okay.
They said
thank you.
I think when they see SC, they're like, oh, slam dunk. I don't have to do much. I just gotta make sure she gets her eyes checked and her hips checked and we're done. And I was drinking the Kool-Aid too. I thought my sickle cell was gonna be the kind I was gonna drift in, 100, 120 years old and not have a complaint. And I didn't for a very long time. I said, ooh, I'm beating this, I'm winning.
Yeah.
And then it started to show up, creep up on me, and I was like, ooh, I'm not winning.
You need to share that out.
Go on and say it. It's hard because I might start crying.
Just share what you felt.
Okay. The reason why I asked that is that not living with SS, I grew up in a family, and my grandmother was a nurse also. And I would be told from the time that I was a child, you don't have sickle cell anemia, you don't have full-blown sickle cell, why are you sick? And I would feel like I didn't qualify to really be sick. I wouldn't feel like I was faking, because if y'all know me, I'm just keeping real at all times. But I would feel like I shouldn't be sick, so I hid myself. I sequestered myself. And as a result of that, when I would have dactylitis or whatever as a child on up, I just didn't feel like I could show anybody that I had sickle cell. And then even if it came up, I felt like they invalidated me. I couldn't be me.
Was almost they're teaching you to
deny myself.
Exactly.
Literally deny myself.
You can't be authentic.
And dismiss myself, where I put myself in life-threatening situations. I've been amongst family members that have literally ignored me. I'm hopping. I'm literally because I have AVN, bilateral AVN, avascular necrosis. You and I, we
I'm
know
in that
Renee.
club.
And I'm hopping, and
That
I'm
hurt.
literally dragging, there have been times I've crawled across the floor to try to go to the bathroom, because I could not walk.
But
But
I
I-
just remember you in DC.
Okay, see, she gonna tell on me all. You know how she tells on you with the doctor and the healthcare, she gets me. So I've lived with that. I've lived that I couldn't be who I am. And then, you know, from the the grandmothers, the parents, the spouses, the siblings, all throughout my whole family. I have a sister who's a beautiful person, and she was like, because she came in some of our support group meetings, she's like, Sheila, I didn't know you were going through all that. Because see, there's like two Sheilas. There's sick Sheila and well Sheila. And because I have been indoctrinated that I don't have sickle cell anemia, you can't be sick. Those, you know, I hid myself.
Yes.
When I
yes.
was really sick, I didn't communicate it to people. I mean, I'd have to be bad to go to the hospital. And I kind of became, I'm a reader. I would just go in my bedroom and sequester myself. And my family did not see me. Many of them did not see me sick. All they saw was bubbly Sheila, healthy Sheila. And so that has affected my psychology, because I've lived feeling, you better be glad you don't have SS, girl, what you complaining about? And it really messes with you, because
That's a knife to my heart. I went to sickle cell camp, and I was a camp counselor, and even my campers, or what you call it, my girls, they were like, you should have no complaints. Your life should be on easy street. And I drank the Kool-Aid. I was like, I should be on easy street. I'm dancing, I'm running around. And then 2 seconds later, I'm like, well, I feel like I got SS right now, because I'm, I feel like I'm circling the drain, but you're not really seeing my experience because I have SC.
Yes, and I've been around some people with SS that have been hospital have less symptoms, and I have this supposed to be good one, sickle beta thalassemia plus.
Dr.
And it's-
Shirley
and it's-
says the worst
it
kind of
messed with
sickle
my mind.
cell
It was so.
is
that-
the one you have. She said, doesn't matter what genotype. She said, if you have sickle cell, that's the worst kind.
Because sickle cell has the potential to show up and show out whatever disease you have.
Right.
I mean,
Yeah.
And so that was my darker side, like when you're.
I was like, okay, bring us home now.
Yeah. I'm gonna make it good. I'm gonna make it so good. You're gonna love it. You're gonna
All
love
right.
this. First of all, just to see you, your smile, your dimples,
Those
your
dimples.
delivery, because I know, isn't she? She's just precious. What has been an active part of the sickle cell community? How has that benefited you and your family?
The love, the acceptance, because we're not always accepted in normal circles, but to have our own family, our own warrior family and their families. I mean, past my mom, I've known her since, well, a long time. And just so happened, a friend of mine that lived in LA invited me to Cayenne's summit, and it was in my hometown of Sacramento. I said, oh, well, I definitely want to go up there. And now they've become my family.
Yeah.
And the advocacy, I've just gotten better and better and better at it, how to explain sickle cell and how it shows up different for everyone. And that's why I always say, we're snowflakes. Not all of us are we all show up differently. And sickle cell shows up differently.
Yes.
And I think that was my advocacy at that point, because we had been cuckooed on this SCers.
Yes.
And the thalassemia. I didn't even know about thalassemia until maybe
Well,
10, 15 years ago.
the sickle cell disease except SS has been made to believe that it was a less severe disease. Sickle cell shows up and shows out the way it shows up and shows out, and so, so whether you have SE, SD, SC, there are hundreds of different types of sickle cell disease, because there are hundreds of different types of abnormal hemoglobin.
Yes.
So it is whatever it is, and it shows up the way it shows up.
Yes. I would say the most important thing for me, advocacy, was seeing that how SC was treated versus SS.
Yeah.
When we were all in the same clinic together. It's almost like we had our slug
Because you shouldn't be bellyaching because you only got SC.
And the first thing that came thinking in my mind, I was like, oh, the field Negro and the house Negro. I'm like we're the light skins. We're getting all the, we're out there living life, and the dark skins are out there just toiling away.
Yeah.
And in reality, we needed to come together, but that was divisive, right? That was separating us in our own community, in our own sickle cell community. It was like, I'm better than you because we have a disease that is potential to kill you.
Yeah, that was lack of education on the healthcare providers, because they felt like those of you with the higher hemoglobin should be living better lives.
Yes. And for the most part, we were, but when we weren't,
you had higher hemoglobin. You had higher hemoglobin, and so you could not be suffering in the same way as those people with 6 grams of hemoglobin, and you got 10 grams.
Yes.
Okay. So that's really what that was all about.
And think about all the drugs that we can't take, or medicines that we can't take because we're in the SC category versus the SS category.
Yes.
So you have to
I
suffer
feel
longer.
like we get the crumbs.
Yes.
And we should get a whole cake too, right? I
But
mean, we
then
have our own.
They later learned that because of this viscosity with your higher hemoglobin,
Yes.
you have more bone damage and other damage.
Eye.
And eye damage, yes.
Oh, yes, my
And
eyes are
so-
challenged,
and
my
so
hips are
then
challenged.
There was another dive into sickle cell. And what we came away with was everybody suffers with sickle cell.
Exactly.
There was like a hierarchy. It was a caste
Yes.
system.
Yes.
It was a
yes.
caste system.
Yes.
Like,
It was.
oh, if you're SS, you're at the highest caste, and if you're this, you
Yes.
really don't
And
you don't qualify.
Even the patients with sickle with high persistence of fetal hemoglobin.
Yes.
So they have very high fetals, and remember, fetal is that hemoglobin that protected you in
Yes.
utero from having all the complications of sickle cell disease until you came through the birth canal, and you no longer, your hemoglobin changed to your type of hemoglobin after a period of time.
My first hip surgery, I had a wonderful hematologist, Dr. Logan at Orthopedic Hospital in Los Angeles.
I knew Dr. Logan.
He was awesome. He's the jazz man. He got my blood and stepped into my office, and we looked at my blood under a scope. And he goes, "Did you know you have so much fetal hemoglobin?" In my mind, I'm thinking it's all gone by the time you're an adult.
Yeah.
And he was so jazzed about it.
Yeah.
Use the pun.
Uh-huh.
And he made me jazzed. I was like, what? Let me see. I think that's part of the experience too. People living with sickle cell or any disorder, you should be like, I want the doctors to say, look at your sickle cell, look at your diabetes, charts and graphs, and like make your, integrate it into your own care.
Yes.
And be excited as he was he was excited about my high hemoglobin. I was like, well, maybe that's why I've been so sick. Yay.
Yeah, the doctors that I work with did that a lot with patients. They looked at their slides, because when we had their blood drawn, there were slides made also. And so when the slides came, we were able to show the patients their particular slide. So if you had SC, we could show you an SC slide, and we could show you someone else's SS slide. And you could see the
I think that we
differences.
need to bring that back.
Yes,
I just remember
yes.
that was 20 years ago, but I'm
Yes.
still excited
So
about
you
it.
can
He
see
was
the
excited.
target cells on the individuals that had SC, and you could see the sickle cells on the individuals who had SS. And so it was an opportunity to really teach young folks about their disease in a way that they really understood.
It is visual.
It's
I mean,
visual.
pictures speak
visual.
1,000 words.
And I think that's one of the things when the transition, not just regular advocacy, but transitional advocacy,
Yes.
being a young warrior, turning into an older warrior, and reaching back and pulling
Yes.
up. I didn't have that
And
experience.
also-
I didn't have that education. So
Yeah,
that's one
and
thing that I'm super passionate about now. Is like, I want the 12, 14, even younger. What do you mean you don't know your genotype? I've got to get on them. I didn't know the significance or the importance of it, but I knew it my whole life.
Yeah.
And I was thinking, well, how did you get a diagnosis and you don't know your genotype? So, I mean, just, a little tap, not, making them feel bad about themselves, but I want them educated. I want them
Yes.
empowered.
And so many people don't know their genotypes.
No.
They really
No.
don't. They really
truly don't. What was I gonna say? See, I forgot what I was gonna say.
What?
Oh, I know what I was gonna say, Renee, because Renee, you ain't quite,
like paparazzi.
you're not quite Medicare qualified. You're a decade or two younger than me. That transition, we talk about transition from teen to adulthood. Given that we're all, including Dr. Raleigh, we're all growing past our 50s and 60s and
Our
into
golden
our
warriors.
70s, we need another transition program
Exactly.
of golden warriors that speak to what you brought up so eloquently, which is not only are we human beings and we're lifing and we're living with sickle cell disease, but we're aging.
Yes.
And there are different medical things that happen to all people who are aging. And those complications or
And
whatever
they can
can
trigger
be
an
exacerbated because of
Yes.
sickle cell.
Yes.
In a whole, I know it's on my heart and mind, is that attention to aging. And we're blessed that this is, Pat knows, this is like, we're the first generation per se, for quantities of us to live well into our 70s and 80s. So there's a ministry there. There's a platform that we need to work on.
I used to call them unicorns. I was like, you're 70? You're 40? You're.
So the
In my mind, it was mind blowing.
So question,
other thing let me
Can I
just
make
throw
my
this out
question?
before.
Can I do my
Let me
question?
just throw this out. We were talking about the blood smears and looking at people's blood smears. One of the things that we don't do in the clinic settings and stuff now is to show people their blood smears. One of the teaching things that I was able to do was to show people their red blood cells and show them how close they were together. What does that mean to you? That means you're dehydrated. Okay.
Yeah.
And so the more liquid your blood is, the further apart those red blood cells are going to be. And so I could say to them, "Oh, look, your blood looks kind of yellowish. You know,
Your
that
body's
means
telling
that
you.
you got jaundice going on. You're breaking down red blood cells. Oh, look at these red blood cells. Look how close they are together. That means you're dehydrated. You're not drinking enough water." So all of that teaching kind of stuff was possible before.
And it's positive.
And it's possible again, you
And
know.
it's
But those are
positive.
the kind of things that you have to teach people living with a chronic illness so that they understand the significance of me saying to you, you look, your skin looks really dry. You look yellow. You know, that means you got more hemolysis going on. That means that you're dehydrated. What did your urine look like today? Was it brown?
Oh, that's my
it's
mom in a
supposed to be
nutshell.
crystal clear, you know.
I called her the
Those
urine
are the kind
inspector.
of things that the lack of teaching all those kind of things, because you go into a doctor's office, you see the doctor, you don't see anybody who spends time teaching you anything other than saying to you, "Oh, you're okay, you can go home," you know. But those are the things that helped people live to be 70 and 80 years old.
I say people, you can
Because
have
they
the
had an
you can
awareness,
have,
and that's an awareness that's being lost.
you can have the
because we're not
Bible
educated.
preached at you, or you can read your own Bible. I always tell people, read your Bible. Because
Yes.
whoever's in the pulpit, you don't know what their agenda is, but you can read for yourself. Like you can see your own cells and you can see your own medical records.
I think Mary.
So we
Yes.
have, Mary have a question, and then we're
Yes.
going to be winding down, actually. Mary.
My question is, tell us about a moment in your life or a day or a month or whatever, it doesn't matter, but just something, and I'm a romantic, so whatever you want to share. But just think about a moment in your life when you completely forgot about your disease. It's like it doesn't even exist.
And wrap it around your mate. 'Cause I wanna know-
No, I didn't say that, Pat.
I want you to share, you know.
Yes.
Because the desire of most women or most men is to have a mate.
Companionship.
So how did you get there?
So there's two questions,
Yeah, there's two
Mary's
questions.
and Pat's. So Mary.
Any relationship, like you said, you have to invest, right? And when you're with your significant other, or you're with your best pal, or anyone that brings you joy, you can forget, and that's the gift of friendship, the gift of relationship, right?
Yeah.
And especially if you're with another warrior, we know that we need that distraction. We know we need that break, but not only a mental break, but a physical break. So one thing that my husband's a musician. And, if I hear a saxophone, even if I'm in a tent, I perk right up. And my mom, she always thinks any jazz and it has saxophone. She goes, "Is that my son-in-law?" Or she thinks that's derogatory. She goes, "Is that my son?"
Yeah.
And so music and family, friends, like that connection to me, I can lose myself. That is my favorite thing. And even in the romantic side, when I was being courted, we went to jazz festivals. We went to the beach. There's things that are I'm a very frugal person too. I like things low cost, but things that are enriching. Beach, reading. I'm an avid reader. Well, used to be, have a pretty busy life, but I have a stack of books that I need to get to. Those are the things that take me out of myself into a whole new world that I'm thankful that my friends and my family can do for me. And, romantic and not romantic. That's the most awesome. They think that they're giving me a gift, or I don't know how to explain it. It's a reciprocating gift.
Yeah.
It's a gift to me in the fact that I'm not seeing we're not talking about my disease, we're not talking about my ailments, and you're just so relaxed and you're just vibing and you're just, oh, this is awesome. It is such a gift because we don't get long stretches sometimes. Especially as I'm aging, I feel like I'm getting less and less time to just really be without Sickle. So I want her or him in the corner somewhere, and I don't want to listen to anything he or she has to say. It has to say I want to just be in my own lane with blinders on and not. But the reality is, we know that we have to pay attention, otherwise it could be a very lethal situation.
And then
Excellent.
We've come, we can.
question.
Last question. Go ahead.
You
Kimberly.
answer that question about her relationship.
I think that's a part 2 to that. It's Cliff Notes. Bet.
Good point.
Right? You can teach someone about sickle cell, but they haven't lived it until they lived it with you. And we have had some ups and some downs
And some around.
and a baby. So it's twists and turns. It's a roller coaster, but I would say that the ride has been phenomenal. I didn't want to be married. I didn't want to have children, all because of sickle cell. And now I'm married and I do have a child, and I can't think of myself without my baby.
Right.
And he's awesome. He's the best in the whole wide world.
And your hubby.
Oh, yes, and my hubby. Sorry. I know. Oh, my poor Tom, he gets the crumbs, but he really is instrumental. And because he's so relaxed, and I call him like he's mahalo, he's a musician. He doesn't stress a lot about even the small stuff and the big stuff. So, I kind of say, hey, babe, I'm sickle selling here. Sickle cell is showing up. Yeah. But he has that ability to say, okay, sickle cell's here, and we can continue to do these other things. Like he pushes me in a healthy way to say, don't stay in that spot. And some men can, if they can't help you, like physically, tangibly help you, they can tend to shut down and be, introverted, because that's, the stereotypical they bring home the bacon and we make the bacon, right? And then sometimes you don't have the ability to share the bacon. I mean, the bacon is brought home and then it's just sitting in the pan because the person is supposed to make it is sick. And that's the give and take of a good relationship, a healthy relationship, is knowing, I think Brene, I can't think of her last name. She says sometimes you show up and I just have 20%. And so that person says, okay, well, I got 60. And so, okay, 2 and 6 is 8. So we don't even have 100. But we're going to deal with that 60% the best way we can. And you have to learn how to delegate. I'm horrible at that because I'm a taskmaster. But I'm getting better as I'm getting older to not be so about myself to where I don't want to inconvenience anyone else. I'm starting to speak up and speak out. And even telling my mentees, you're not bothering me. You have the ability to speak for yourself, speak for yourself. And when you don't have the ability to speak for yourself, let your mate fill in those blanks. Let them fill in that space where, and this lets you be and heal. That's the best part of a good relationship, is whether it's a friendship or a marriage or a significant other, letting them take care of you. Because I took care of myself for so long that it's hard for me to teach him how to take care of me, because I have PhD in Renee, right? I'm a doctorate in how to take care of me, and to learning to like let the walls down. Because when that pain hits, the walls go up. You think emergency room, not going to be a great idea. How do I prepare for the emergency room? And you kind of just think about, you're so micro-focused that you don't think about your family at that point, because you're just thinking about survival. And when your mate has 10 or 15 minutes to say, hey, babe, stay focused. We're in this together. We're going to get you that care. They say mic drop. That's
Yes.
the best.
Yeah.
That when somebody shows up for you, your friend, your mate, eyeballs just welling.
Yeah.
I mean, the Thanksgiving and the praise that I give God for the people in my life that show up and show out for me.
Yes,
And sometimes it's even a perfect stranger.
right. True that.
God just sends all his angels.
That's right.
And I'm just so blessed, and I'm so thankful to have this platform to make sure that the people that are coming behind me don't have to suffer in silence. And some of that was my own naivete and my ignorance. And now I say, when it's your turn, you can come out. We all have a coming out story.
That's right.
And when you come out, just little by little, figure out what you want to contribute to our society. And when you find that, you'll shine, and you'll be so helpful and so kind and so generous. The outpouring of just reciprocating love and respect, that's the one safe space. I mean, we got some creatures running around that can, make it kind of ugly. But in general, when I know my sickle cell family is going to be somewhere, it's a party, even if my sickle cell's at 10.
Right.
In my mind, I'm like, ooh, I can be myself. I don't have to explain anything. There's no backstory. I can be over in the corner just, I'm so in so much pain, but I'm still enjoying it. Don't stop on my account, and they know. They know when it's time to say, Renee, it's time to take you, get a heating pad, let's take you to the emergency room. But they let you be you, and they don't poo-poo you. They don't baby you. They respect you. They respect your, like, I don't want to go to the hospital right now. But then they always say, we've done it your way. You're bright. Jaundice is telling me hospital time. You're limping. It's hospital time. And that gift is wonderful, because they pull you out of yourself, because you think, well, no, I got it. Sometimes I ain't got it. And sometimes that your significant other or your best friend, they said, you know what? We're carrying you.
Yeah.
We literally and physically, mentally are carrying you to this next space that is going to hopefully be safe. And if it's not, we're going to show up and advocate for you. That's the best experience you can
They're
ever have.
hearing you, but they also see you.
Exactly. See.
Yes.
And I didn't even think about that maybe 10 or 15 years ago when I wasn't seen at the hospital. That's when I thought, man, I'm going to turn your pain into passion. And I said, not on my watch, everybody's going to be seen. I may not be able to help you in that moment, but I also feel like part of me the one thing I like about me, I could like connecting people. I don't know about something, but Dr. Rowley knows. I can give you Dr. Rowley's number. I can give you Mary's number. I can give you Sheila's number. And you guys can connect. I don't know everything, but I know some people that could possibly help you. That's the best thing I like about advocacy, is connecting. Because that's how I got here. Somebody connected me to Dr. Rowley.
Yes.
Yes. Pat,
Yes.
we've known each other a long time. and so that's what I would say about relationships. Vet, and educate. Because we grow, right? We evolve. Who I was 20 years ago is who I'm not. I'm not that same person now. And I have to speak up and say I'm not that same person.
You use the word vet. And, they're receivers because we give care. Vet, and what you said also, giving, the joy of giving, and bless.
Yes.
Though that we live with sickle cell stuff, we should not minimize how much we also give.
Yes,
right?
Yeah.
We give a lot too. I mean, just the fact that we live in this condition, I think it allows us to have some inborn compassion.
yes.
We could see
yes.
somebody with any kind of condition or deficit and we could.
And we zoned in.
So we
Yeah,
go
get
in,
there.
we go in.
Yes,
We, because of having what is titled an invisible disease,
yes.
Yes.
sickle
Yes.
cell can be called, because all of us aren't obvious, so to speak. Some of us, we show up and they go, well, what, you ain't sick, or what's wrong
Yeah,
with
you
you?
don't
You
look
don't look
sick."
like it. That's it, Donna. You don't look sick. When
Yeah.
we see someone who's struggling and that thing may not be so overt,
That's our superpower, to
it's
see
our
somebody
super-
else, right?
that's
That's our
I love the way
superpower.
you put it. That's our superpower.
To see somebody else is
Literally.
not
And
being
the need
seen,
in-
but we
in-
see them.
Yes,
Because we know how we felt when we're not seen.
when we're not seen and we're not supplied.
So can we go around the room and have each person share what they think was the most profound thing they got from this?
I can get out the hot seat, right?
So, when you come up to the front and you.
Let's give Renee a big hand.
This was very, Renee, first of all, thank you. This was very powerful, and I'm glad that you all had a chance to ask your questions, because now I think it's even more, she's bigger than life because you've asked your specific questions.
I like that.
So what we're going to do as we wind down is, let's go around, starting here with Mary, going around this way. Just one thing that touched you, that got into your soul, that made you think, whatever that might be. And then what we're going to do is then we will end, and but we have this room. Oh, okay, thank you, Renee. The Facebook user. So we have this room, and they told us how to get out, but once we leave, we're locked out.
Yeah, once we go out the door and lock. So we gotta make sure we gotta clear it out.
So why don't we go around and just one thing, Mary, that
One
that
thing,
touched you about Renee's story.
I think when you talk about school, that you would have desired to experience different things at school. I think that's profound, because even when with that desire, I think it was very unique. Your experience was very unique in that sort of way. Like I think sometimes we do feel limited, but you were not limited. You were just experiencing a different way of experiencing yourself within yourself. So I think that's profound too.
Thank you, Mary. Donna?
I think just the fact that somebody in your family would not accept what you're going through and tell you, oh, you only have this, you're not sick, is like, that gets to my heart, like, just,
Education, right?
Yeah.
Education.
yeah.
Thanks, Donna. Sheila?
For me, Renee, it was how you continue to evolve from your 6th grade self and well into what you will be heading for in about 20 years, your 6th decade self.
I love it. I'm gonna hold it at 36.
I'm holding, yeah.
Pat?
I don't know where to start. I love your creativity and your intention to design as you crafted your life with sickle cell disease.
Tony?
They say on the shoulders of giants, but everyone in this room, even though I know you and I just met you, you've already contributed to my life, so I can contribute to someone else's life. So I say it's a community affair.
What comes to mind when I got out of this is warrior, never give up, never give in.
Yeah.
Just keep battling every day.
Yes.
Thank you.
That's
And on the days that you can't, because there's been several days where I wanted to give up, and I thought I did give up, and then my friend picked me up, and she said,
And shook you and said, what the hell am I doing?
she said, have your pity party for today, but
Yes.
tomorrow we get back to work.
Yes.
And here's a piece of chocolate.
Chocolate always makes you feel
And
better.
here's a glass of wine. Yeah, I'll be like that.
She's probably allergic to chocolate.
Wine and chocolate.
I just was at
Wine or
cheesecake.
chocolate.
Oh.
You made it.
It's just, only thing that comes to me is your joy for life.
And I get that from my granny.
Yes.
She, through it all, I always say, when I grow up, I want to be just like my granny. Not highly sophisticated as far as academia, but everything I am or know is because she loved the foundation of us, all of us. Every person that was in her presence was a superstar.
Yeah.
It is the person that maybe had 4th grade, 6th grade education, but she would never know it. She taught me everything I know about hospitality, making somebody feel welcome, being seen. That's the best gift you can give to somebody. Said, I see you, I love you, I acknowledge you. And that's her legacy living through me, is hospitality and joy. Because she's had many a hardship, segregated South, came to America. The South to me sometimes is not America. She came to California, and she raised her children here in California. Has a ability to be educated by the California, and public educational system. Some of it great, some of it not great, but I attribute everything I am to my foundation, which is God and my grandparents. And they've just been loving, kind, generous, and I just don't feel that anybody should be stingy. And she was never stingy with us, even if she just had one little grain of something. She figured out how to divide it. Because she said, you don't show up with something for just one person. You show up for everybody, and you don't show up. And so that's how I am to this day. I tell my son, even if you're bringing napkins, show up with something.
That's what.
Yeah.
Kimball?
A lot of stuff to unpack, so many different things. I mean, so many key points and key ideas and key notions. But to summarize it all in a simple statement, and which is why I wanted to ask my follow-up question about planning, but we can talk later. I think the biggest thing I got out of all of this and talking to everybody and getting to know everybody, but especially your story in particular, Renee, happiness is a choice. And I think the label warrior goes along, it's synonymous with choice, because we're choosing to label ourselves as warriors or be a warrior or act in a warriorish way because we just don't want to be unhappy. We just don't want to let the world put us down. We don't want to feel like we're unempowered. We don't want to feel like we can't be ourselves. We want to choose to fight to represent ourselves because in a nutshell, that's happiness. Like, we just want to be happy. And at the end of the day, no matter what anybody says, books, like, oh, so you're depressed, so you have to be depressed. No, I've never believed that. My mother never has. It might be a generational thing, I don't know. But my whole family, as long as I can remember, I was always taught you can choose to be happy, no matter what. Whether you have a disease or not, whether it is or not, like, you can choose to just wake up and just smile. It's not easy.
Yeah.
But you always have that choice. And I think Renee is a huge example and something that I would always parade around to any person in the world to be like, here's what I mean. Like, don't give me an excuse. Don't tell me, oh, I can't choose to be happy. You can. You always can. Now, I'm not saying it's going to happen all the time. I'm not saying you're going to be happy trying to make that choice, but you can always make the choice. So I've always made the choice to be happy regardless of my circumstances that I've faced. And I think Renee is a great example of that. I'm so happy that I heard this story because that's the best thing. I mean, you even said you didn't want to be married to have kids and you chose happiness because that person brought happiness to your life. And now look, it's choice. You can choose to be happy. And I think that's the biggest example. So thank you.
So when somebody delivers you some lemons, make some lemonade.
Yeah.
Yes, that's right.
And some
Or
lemon
make
meringue
pie.
pie.
Lemon pie too.
Lemon tart.
Lemon tart.
I say make sweet potato pie.
Choose whatever you want to eat that makes you happy.
Dr. Brawley, what's yours?
So, I was going to say something similar, that one does at some point, without knowing, chooses, decides that they're going to be happy. And so only because the opposite doesn't feel good. And it's a roller coaster. And so no one said that being happy, I mean, just because the person is happy doesn't mean that their life is not challenging.
Right.
It just means that the opposite, they choose not to fall down that rabbit hole because it's very, very hard to get out of. And the more with sickle cell, unfortunately, and the complications, it's very easy to, when these roller coasters happen, for some, so we're thankful for those who choose it, but for some, that rabbit hole goes down and it's very difficult for them to get out.
Yes.
And it's to the point that they've actually just said, I'm done. And we've met people like that. So we're very thankful. I'm thankful that you always say yes if I ask. And I try not to ask too often, but you are one of our go-to people because you do, you come. You give us 2,000% of yourself, Renee. You are a mentor to the mentees in our transition. And you share your story with the legislators, so everyone doesn't know. You show up when we ask. So for that, I'm always very thankful for you. And
It's an
so
honor and a
happiness and joy, though you decided, yes, this, I don't think you think about that. You just think about living and how it appears is that it's joyful and that there's happiness. And at least your tribe does not allow you to go down the rabbit hole. And for that, you are very blessed. And so it does leave us with thinking for those that do not have that. And there are so many who don't have those persons to catch them before it goes too late. So seriously, I thank the Lord for you, for our path, for how you integrated yourself in the community. You have a role with the legislators and with the adolescents, for the mentees. You're mentoring the mentees, for educating providers. So without you even knowing it, look how whole you become in the sickle cell community. So with that, I'm going to say thank you. Thank you. And so, and with that, everyone, that does conclude, that concludes this in-service training. So we thank you for joining. This is being recorded. It will be available. And so we're going to conclude, everyone. So have a good afternoon. And so for the tech team, you can push stop, what have you. And then for those who are here, we have so much food. And so please make sure that you all take some food. So because can't keep it